now, sir. First, multiple sclerosis.
So, thank you for being here and apologize to see me back again. I hope you're not getting bored of me. So, we'll talk about it on the update. I'm presuming that most of you know about this disease because I'm not starting from a very inception point. But I will talk about few things which are potential considerations in the diagnosis and management. So, as you all know, multiple sclerosis is an inflammatory, immune mediated, demyelinating disease of the central nervous system. So, in the central nervous system, the cells which make myelin are oligodendrocytes, and in the peripheral nervous system, these are Schwann cells. So, any damage to the oligodendrocyte for any cause will cause demyelinating disease. MS is one prototype of demyelinating disease which has yet unknown mechanism of occurrence. We keep on thinking कि इस वजह से होता है इस वजह से, but we really don't know why this disease happens. We're seeing an increasing prevalence of disease in India now, and previously was thought to be rare in 70s, but now we see it pretty often in the clinic, and most of you probably are also seeing. So let's take it from there. So let's look at this case scenario, which is very usual. You'll get in the outpatient residents, you'll get them very often. A young female says that I have this acute vision loss in my one eye, and it started about 4-5 days ago. My vision started to get blurred and now I can't really see anything. And you say आपको आँख में दर्द होता था, कोई movement में दर्द होता था. They will say कि yes, slight movement of the eye was caused pain, but the pain is like not extremely bothersome. There is no history of fever, vaccination, medication intake. She's not on ATT, anything, whatever history you have taken. The past history is unremarkable. You examine and you find the visual acuity is just 6/6. This is a pretty bad loss of vision. Color vision is gone. So this is a classic story of a young individual presenting to you with a monoocular vision loss. A monoocular vision loss in a young individual who has presented with this typical onset of history has one important differential diagnosis of what we call optic neuritis. An optic neuritis means an inflammation of the optic nerve triggered by eventually leading on to the demyelination of the optic nerve. You know that optic nerve is a continuation of the brain, so it is loaded with myelin. So this is typically what the story is. So in the diagnostic possibility of optic neuritis, which is of course the optic nerve behind the globe up to the chiasma, there is one that there could be a possibility of optic neuritis. You will see a similar patient who will present to you with cord dysfunction. He will say, Doctor Sahab, last 1 week, 10 days, say my hand feels funny, I can't lift things, it is a bit numb, and when I'm walking, I'm not feeling very good. Many of these patients with one hand or one arm weakness are generally referred as carpal tunnel syndrome and sent away, which is very bad because these young people typically present what is called the deafferented hand syndrome. They can't perceive things in their hand, they feel the arm is heavy and numb, and that is the presentation with what we call myelitis. A third patient may come to you कि डॉक्टर साहब 1 week से मेरे को double vision हो रहा है. He's a young boy, no history of headaches. You examine and you find there is internuclear ophthalmoplegia. Now there is a specific syndrome where the eyes don't, adduct on one side and the abducting eye shows nystagmus. If you see this classic picture, you know there is an involvement of the brainstem because the central pathways have gone. So the third presentation is of the brainstem. So you can have an optic nerve, commonly a cord or the brainstem. These are the three typical presentations, mixed and matched any way you want, right? And when you evaluate these patients, you evaluate them with a host of workup, which is workup with blood, immunological profile, imaging, and of course CSF, and we're not going to that. So this is the updated Atlas of MS released by the Multiple Sclerosis International Federation. This was released in 2020, and if you look at this, I'll zoom it, India is in that pink part now, which is 0 to 25. The lower denominators are not well known because we don't have a good epidemiology. But I personally feel that it probably could be anywhere from 20 to 40 per 100,000. So we have enough MS patients in this country. And all of us sitting here, clinicians, neurologists, I'm sure keep on seeing intermittently patients with these disorders. That's another important part that we have to understand. The other important part for residents and for neurologists and for people who manage MS is to understand that the MS will present as the first episode, which we call the clinically isolated syndrome. The first episode. Just an optic neuritis, just a cord, just a brain stem. And if this patient has got more than one attack, then you typically say, oh, this is relapsing remitting MS. So that's the second variety. The third is the patient has RRMS for 4 years, 5 years, 6 years, 7 years, 10 years, but now he tells you, doctor, for the last 6 months, I just feel that I'm going downhill. You observe and you see his walk has, he started to take more support. This is typically what we call the secondary progressive phase of the MS. And the dictum in the treatment of MS is that we want to prevent these patients to go into a progressive phase with whatever best efforts we can make. That's a dictum number 2. As residents, you must know. Of course, there are patients who present to us in that phase only because they never took treatment, or in whom everything you did but the disease went to that phase. That's the most other important point. A small group of patients is who never have attacks, but they start having slowly progressive downhill course for 6 months, 1 year, 2 years, and by the time they present to you, they already have some deficit. That is called the primary progressive phase of the MS, type of the MS. So we have typically 4 types: a CIS, a RRMS, an SPMS, and a PPMS. I hope these terminologies are not difficult to remember. What I need to show you in these green bars here is that these are the relapses. You know, 1 attack, a second attack, a third attack. Now this way the patient came back. In this, the patient has not come back to its normalcy. So he's already started to become disabled. And this graph is slowly getting worse and worse and worse upwards, which means there is a slowly increasing disability. Now we have more and more evidence coming from MRIs which shows volume loss and atrophy. So we are learning from this point that MS diagnosis should be made early and the treatment should be made early. And we should prevent these patients to slowly deteriorate. So picking them up early is important. Now I'm just trying to show you this diagram because for students, we are learning more and more with the immunology of MS. We still don't know the cause. Honestly, we don't know. But we know that in MS lesions, there is a lot of initial phagocytic activity, which is mild. But as the phagocytic activity increases and the patients start to develop loss of function in the acute phase and in the chronic phase, they will start developing progressive loss of neuronal functions. And that is slowly we are learning more and more in the immunology of MS. We used to always treat MS thinking it's a T cell, we should target the T cells. But over the years, we've started targeting the B cells also to reduce the immunological behavior. So we're learning slowly more and more about these different cell types. And this is of course a very basic science, so I'm not really dwelling much in detail about that. Now what I want to tell you in this typical picture is the causation hypothesis of MS, which has grown over a time. Lifestyle factors, smoking, poor diet. Smoking has a very strong risk factor association with development of MS. We always tell all young people who come to us to stop smoking, because that has a strong relationship of development. I didn't know whether the increase in MS is to do with the sedentary lifestyle of all young people. 90% of you sitting here are also sedentary. I don't think you exercise or you have a targeted lifestyle, maybe busy, you don't have time, you get exhausted. And many of our patients, we have not analyzed the data, but I think the majority are very sedentary. So we don't know whether lifestyle is contributing to development of MS. We also know there are some innate immune systems, systemic diseases, and I will just talk to you in 1 minute, some genetic predisposition and something to do with adaptive immunity. We have only 2 large areas of immunological reaction in the body, the gut and the respiratory tract. So we don't know what causes what, and that's what we are trying to learn over a period of time, that it takes weeks to months to years to slowly, get into an active phase. And when you lose that threshold, you will start having progressive loss of function and neurodegeneration, which is probably the phase of secondary progressive MS, where it is no inflammation, but more of degeneration. We don't know. We are learning that as well. So this is to show you the odds. Odds for resonance is the association, what is the strength of association that you may develop or you may have a predisposition to develop MS, smoking and EBV infection. Now, there are many others: infectious mononucleosis, passive smoking, coffee is protective. But two important things that I think are most outstanding are smoking and Epstein-Barr virus. Epstein-Barr virus keeps on coming back and forth in immunology. So, this is one of the recent reviews in 2023. I mean, evolving the new Nature reviews in immunology and microbiology. They looked at all the data and they have kind of synthesized this information that, you have this in the green, the EBV cytotoxic lymphocytes, you have size of the thymus, you have EBV antibodies and the behavior of the TH cells. There is something to do with our exposure to early EBV and development of infectious mononucleosis. Of us don't remember that we ever had one, because virals and coughs and colds are not uncommon in our childhood. But we are never investigated that we definitely had infectious mononucleosis. So there is a strong reasoning now that we are learning that the development of EBV virus in the body leads to a sustained somehow mechanism that triggers immunity over a period of time. And that is something which has been coming back and forth, and a very recent paper in Nature which looked at sera from a large sample in US showed a very strong positivity of Epstein-Barr virus in patients who had MS on follow-up. The sera were collected years before. So there is noise, and we don't know what we will do with this EBV virus. That's a question that we are still unanswered. That's something, a new thing. The other thing I told you about is the gut. And I was talking to one of the PhD students who was talking about microbiome. There is a lot of new understanding about our gut microbiome. It's like vitamin D. We were very excited that vitamin D is associated with everything. Now the new kid on the block is our gut microbiome, because this gut microbiome is a great thing. We really don't know which bacteria are good and bad for us and which trigger immune diseases. Now gut microbiome has been associated with dementia, Parkinson's disease, and in one condition people are working strongly is MS, because we don't know what triggers the gut microbiome to develop multiple sclerosis. And this is an ongoing international MS microbiome study where they're looking at genetics and metagenomics by transferring this bacteria into the rats and looking for development of immunological behaviors, which will probably help us in understanding the relationship of gut microbiome. Because see, knowing something, we need to find a causation hypothesis. And then what we need to do about it. It's like pseudomembranous colitis or C. difficile, where there is now a therapy of fecal therapy. So there have been small studies of giving fecal therapy for these patients containing specific gut bacteria. But it's not really gone on to a treatment still in patients with MS. From there I go on to the more clinical part for the students. There are two things in MS, is what we call dissemination in space, and the second thing is dissemination in time. Now what does that mean? Now I'm already presuming that you know that in MS the lesions are tiny dots. Can I have it? And these are these tiny hyperintense lesions, white, which are generally small, focal, ellipsoid around the ventricle walls, in the brainstem, but they're always very discrete, focal, round to avoid. This is a very classic looking MRI of a patient of MS. And in the cord also you will see short segment lesions, never long segment lesions, right? So what is dissemination in space? You had an optic neuritis in one and you had a cord second time. So it is two different parts of the body that are involved, right? In radiological dissemination in time means that you have basically two or more lesions in among these four areas, which means periventricular, juxtacortical, infratentorial and the spinal cord. Among these two areas should have at least, we should be seeing two or more lesions, right? Now, what is dissemination in time? Let's say a patient comes to you with the first episode of optic neuritis. You did an MRI, and MRI is normal, right? Or you did an MRI and you found 3-4 lesions, so you know this is dissemination in space. But how do you know dissemination in time? Which means you need to know whether this patient had these events dispersed over a period of time. If this same patient follows up and has another optic neuritis or a cord, you know this is another attack, so you're very certain now there is a clinical dissemination in time, right? So what people did was, they said that if you have in the same MRI presence of non-enhancing and enhancing lesions at the same time, that is equivalent to dissemination in time. So I always recommend, and I feel very bad when people come to us just getting a plain MR in the first attack and there is no contrast MRI. So please have a habit of doing plain and a contrast at the same time, so that you can give a more definitive diagnosis to your patient and be more certain on the diagnosis. So that is what is radiological dissemination in time. Now let's say you don't have contrast enhancing lesions and you did a CSF. In the CSF, we send for a special test called oligoclonal bands. These are small proteins which are from single clone and have small, weight nature, and these are picked up by immunofixation, right? So if you have oligoclonal bands positive in the CSF but absent in the serum, same bands cannot be present, then this means there is an ongoing intrathecal synthesis of immune reactivity. Now in 2017 criteria, they have introduced oligoclonal bands as a marker of dissemination in time. So if you have a patient whose MRI does not show enhancing lesions and you find OCB positive and you've ruled out everything else by doing a proper antibody testing, everything, then you can safely say that you have a patient with both dissemination in space and time. I hope this is clear. Am I clear in this? So if you have a contrast enhancing lesion, you can still have a dissemination in time. If you have an oligoclonal band positive, it is still dissemination in time. But the problem which residents do and even clinicians do is they never send a paired sample. CSF sent for OCB, serum never sent. Please send serum and CSF both. Now, ये थोड़ा पैसा लगेगा पेशेंट का, but आप किस लिए बचा रहे हो? वो बाद में फिर confusion. So don't do that. I mean, if you have a patient who can afford this testing, it should always be a paired sample. There is no value of knowing oligoclonal bands positive alone in the CSF, because it will be positive in NMO also, in few percentage of patients. So you will be more confused only. So this is what is this. So what happened in the 2017 criteria is that you can either have a dissemination in time by a follow-up new T2 lesion or a lesion, or a simultaneous presence of enhancing and non-enhancing lesion, or with positivity of OCB. I hope this is clear to all of you. So always look for these two things in your patient, right? So let's look at this example. This is the patient with optic neuritis, and this patient, MRI brain is normal, cord is also normal, so there is no dissemination in space, there are no lesions. But peculiarly the OCB is positive. Now OCB can only tell you that, okay, there is some ongoing inflammation, but it doesn't complete the, the criteria, in the sense that you need to have some brain lesions to say that you have MS. Now for this patient, just finding a dissemination in time didn't help. So this will be put into a typical category of clinically isolated syndrome, who has more chances of developing MS because OCB is positive. So in this patient, what helps you typically is extent of optic neuritis on imaging, and I'll cover that in my NMO talk. There are two forms of optic neuritis: short segment and long segment. If a long part of the optic nerve is involved, like this, a long segment of the optic nerve is involved, it is unlikely to be MS. If a short segment is involved, it is more likely to be MS. Response and recovery of optic neuritis, and in this patient, the importance is to send aquaporin 4 antibody, the NMO and the MOG antibodies, because they could be positive in this patient, because it's just an optic neuritis with no MRI brain lesions. If they are also negative, patient will require a follow-up to make a diagnosis. Now look at this example. This is a patient with optic neuritis. On the brain MRI, there are these 2-3 lesions, and you know these are like looking like demyelinating lesions. You did an MRI of the spinal cord. There is a small MRI lesion, but there is no enhancing lesion. What is happening? Only the optic nerve is enhancing. Now in McDonald's 2017 criteria, they do not allow use of optic nerve enhancement as a sign of dissemination in time. The Magnum's criteria allows, but the experts said that optic nerve involvement is so common in many disorders that we cannot use it as a very specific tool. So this patient, you have dissemination in space, you cannot use optic nerve as dissemination in time, and OCB is also negative. So you cannot, criteria wise you cannot say, but we know inherently that this is looking like MS only and nothing else. Now if you have a patient who presents with a cord lesion, let's say a myelopathy, and you see this, there is a small focal cord lesion, and the cord lesion is also enhancing also. This can be taken simultaneously as dissemination in time. So I hope this is clear. Other than optic nerve, if you see enhancement of the same symptomatic area of presentation has now been included as a criteria for making the diagnosis. Is it clear to the residents? All that. So I'll place it here in this scenario, like this. Now you see, you are applying to a patient who is presenting to you with some neurological syndrome, right? If you have more than or equal to 2 clinical attacks and more than 2 lesions, it is pretty sure that you are dealing with MS based on the criteria, right? If you have 1 clinical attack only, more than or equal to 2 lesions, then, and you have dissemination in time demonstrated by the MRI, you can say that patient is most likely to be having MS. If it is none and your CSF oligoclonal bands are positive, you can still say it is MS. If it is negative, you have to place them into CIS. So you have to use these criteria with a judgment. Now criteria are meant to give you a way forward. ऐसा नहीं है कि तुम as a neurologist, you cannot be experienced enough to say कि अगर OCB negative है भी, brain में clear cut classic lesions हैं, and you will say कि नहीं नहीं तुम्हें MS नहीं है. ऐसा नहीं है. Criteria help you in refining the diagnosis and making sure you're on the right track for making the diagnosis. So in this diagram, it all tells you that if you have a single attack and an MRI positive, very good. If you have no MRI positive but OCB positive, very good. So you can tell your patient, explain them, see we have evidence to say that you have a specific illness, and counsel them accordingly in a gentle manner. You know, roughly opening up the diagnosis and saying MS hai, isme kuch nahi ho sakta. Well, that I've heard people telling people, which is not correct. So that's what is the updated 2017 criteria for residents to understand about relapsing remitting MS. Now this is why I wanted to show you that in MS your antibodies will always be negative, they are hardly ever positive. But your oligoclonal bands positivity is high, it is about 80%. If you have a neuromyelitis optica, your aquaporin 4 generally will be positive, but oligoclonal bands could still be positive, but a small number will be positive. And same is true for MOG antibody disease, your CSF OCB will be less positive than aquaporin 4, but can be positive. So OCB alone doesn't help much unless it's in the clinical scenario of the disease. That's it. So some of our data, and just to tell you that all the people mostly are going to be females in your practice, predominantly going to be females, age be in the age group of 20 to 40. Don't make an MS diagnosis at 70 years, please. And probably not at 3 or 4 years. My youngest child has been about 9 years. But we see pediatric MS now a lot. But most of your patients will be in the age group of 20 to 45, right? That's the usual. And another thing we observed is that they're generally very educated and they come from decent family background. So there is a concern there, and it's considered to be a disease of moderate to high socioeconomic status. Reasons? We don't know. There are a lot of theories behind that, right? What have we learned in our immunology of MS? 1, if you have a long segment optic neuritis, think of alternative diagnosis. Number 2, again like this, and I will talk to you about that in NMO, SD and MOG disease. If you see these discrete lesions in the cord, think of MS in a patient, if you see long segment myelitis, the whole cord is bright, which used to be called transverse myelitis in the background, and बहुत सारे मरीज आज से 15-20 साल पहले इनको टीबी का ट्रीटमेंट नहीं मिलता था जब एक्वापोरिन 4 डिस्कवर नहीं हुआ था. I can tell you patients referred from teaching institutes to neurosurgeons with this MRI for getting a tumor operated, which is a disaster. I recently had a young lady who had a similar picture and was misdiagnosed too, and these are published reports. You know, these cords, long segment can look very large and bulky, and histories are sometimes misleading, so that's possible. If you see this discrete lesions, they are more likely to be MS. If you see someone with hiccups and vomiting, and I'll touch base in the NMO with a a typical medullary lesion, think of NMO. And if you see these large lesions in the brain, think less of MS and more of different diagnosis, NMO, MOG, or some other encephalitic disease. These lesions really don't happen much in MS. They're very rare. Okay. So how do you manage these patients? Relapse treatment, typically with prednisolone for 3 to 5 days. We generally have started to prefer 5 days of treatment now. What I want to just highlight is that always differentiate it from pseudo exacerbation. Patient went on a kind of a tour, got fatigued, and now tells doctor my leg is hurting for one day and I can't just walk. Remember, there are pseudo exacerbations which are just variations from what the patient had because of fatigue, UTI, infection, fever. There was a patient who came to me, my wife gets relapse every month, doctor. I said, well, that's very unlikely. And what happened was, next time we say, okay, you get her admitted. Every time it was very high grade fever and UTI, and she would go down. Infection was treated and she would become okay. So remember, pseudo exacerbations are very common in these people. The other thing I want to stress, which is not very strongly evidence based, but guidelines were published previously as to there is probably some role of moving up the ladder in an MS patient also who does not show significant benefit of a relapse with just steroids alone. That's my personal opinion, and that is also there in previous American Academy Neurology guidelines on plasmapheresis. It's a level 3 evidence, but if a MS patient with a bad relapse is not improving after 1 week, 10 days, up to 14 days, maybe, I don't know the real sweet spot, you should strongly consider a next level of immunosuppression. I've seen in MS also patients being left with some sequelae. So I personally feel that they are also candidates for plasmapheresis, like we do for NMO and MOG diseases. So do keep that in back of your mind. Majority of your MS patients will improve with steroids over the next 1 week to 10 days. But you need to look at those patients regularly and make sure that the patient is not someone who's not improving. There, I think there is a role of plasmapheresis in MS relapses also. That's my personal opinion, and there are publications on that as well, right? IVIG is very uncertain, so I will not say, but okay, if you have a patient who's not doing well, Plex is contraindicated for some reason, and you want to give the benefit of doubt, it makes no harm in trying IVIG as well. There is small evidence, but it is there. The next thing in MS treatment, anything new? Well, we always hope for a cure in MS. Unfortunately, we can't label it as a cure as yet because we don't know the longevity of the benefit in most of these patients. And there are many factors which lead to, why patients may not improve. Some of them may be MS factors, a bad clinical course, untreated patient, long history, or it could be, diseases which are affecting strategic areas, brainstem, spinal cord, where the deficits can be very bad and can be loomy as well and last longer. Or patients' comorbidities could decide on your decision to give appropriate treatment at the appropriate time. It's like a lady coming to you today in the OPD has had an optic neuritis 6 months ago and is not on treatment, and you've now made a diagnosis of MS. She's almost 31 years of age. She wishes to have a child. I would prefer that she does her family first and then gets onto a DMT. So all those decisions need to be relative to the patient's concerns and what stage the patient is in and how unstable the patient's disease is, right? All those needs to be made in a point. Now let's look at this timeline of development. I mean, we really moved from 1993 jab sirf interferon hota tha. And now if you look at this whole journey in 20, I think we have close to about 20 plus drugs now for treatment with medium efficacy and treatment with very highly effective drugs. And that's what the journey of MS has been, with a lot of these improvements over a period of time. And for residents, the DMTs are two types, the injectables and the orals, right? DMTs mean disease modifying treatments. In the injectables, we have interferons, which are of many types. Honestly, patients don't prefer interferons anymore. Injection koi nahi lena chahta, right? If someone is very bad in its compliance and says, doctor, see, I can't take a tablet every day, then there is a role of this pegylated interferon, which is given every 14 days as a insulin-like injection, right? Now, we have these high efficacy drugs. Mitoxantrone we don't use anymore, it's not available. Natalizumab is one of the very effective drugs. We have ocrelizumab, rituximab, and alemtuzumab. These are all drugs used for, which are labeled as drugs with high efficacy, right? So you can make a choice. Then we have the newly approved ofatumumab, which is also available now. These are the oral tablets. When we had when patients could not afford interferons, we have used a lot in our patients azathioprine as an immunomodulator in MS. Years ago, when these, the oral dimethyl fumarate, teriflunomide were not available as generic formulations. Now, for last 2 years, 3 years, in India, we have generics of both dimethyl fumarate, teriflunomide, and fingolimod, which cost anything between 2,500 to 4,000 per month. So the treatment has become very reasonable, and most of the patients can get treated. So that's another update for residents to know, that we have these generic formulations available and which are not very expensive for the patient. So most of them end up getting treatment with these different medications. Now there are these two approaches in MS, like any immune disease. On the left side is what we typically follow, and most of the patients are happy doing. It's called the escalation approach. You start with a medium efficacy drug, like interferon, or I start with oral dimethyl fumarate, or a medium efficacy drug, dimethyl fumarate, or a slightly more efficacy drug like fingolimod. And then I see the patient does well, I am happy, patient is happy, we continue with monitoring. And then we go up the ladder if the patient continues to show disease activity, like relapses, disability is increasing, we shift the patient quickly to the more effective drugs that I showed you, natalizumab, ocrelizumab, rituximab, and others. In India, rituximab is one of the most commonly used drugs, and I'll touch base with that. The other approach is that you see a patient who is already very aggressive. In the last 1 year, he has had more than 2 relapses. Patient's disease activity is high, MRI is flooded with lesions, and there is already disability due to previous relapses. In those patients, you can go directly to what we call the induction route. Start with the most effective drug first, get the patient on the line, stabilize him, observe for the next 2 years or so, or 3 years, and then de-escalate to a more maintained medium efficacy drug. I hope this is clear to the residents here. So there are two approaches in MS also. Most of the time it is the escalation approach, and in a small population this is the induction approach. When we talk to the patients and we explain them this, there are patients who have told me very clearly, doctor, I want a more effective drug, I don't want to go to the escalation route. Because they say we want drugs which have clearly more efficacy, where my disease needs to be controlled. I'm a very active young person, I'm not going with this approach. We give them, we make a shared decision making, we explain, and we get them right on this route as well. So the routes can be changed. I mean, it depends on how you look at the disease and how the patient perceives the disease, okay, without a panic reaction. So there is a Treat MS trial specifically for this, which is going on internationally, which is comparing drugs which are medium efficacy to start with versus a very good drug a more effective drug to start with. Hopefully we may be getting results in next year about this trial. So these are the few medications, and this is how it typically works. You start with mostly the first lines, these oral forms or dimethyl fumarate, and you go up the ladder whether you want to choose rituximab. I specifically put rituximab here because rituximab is an off-label drug in MS typically by the FDA and by the EMA, but it has enough evidence in the literature for use and a lot of practical evidence in the literature for use. In India, this is one of the common drugs that is used when patients cannot afford natalizumab, or for some reason cannot be given natalizumab. And these all other drugs like, ofatumumab or let's say ocrelizumab can be very expensive for the patients. So we frequently use rituximab in these patients. It is a pretty cost-effective drug in most of these patients. And we go up the ladder. And the last ladder that we have to follow many times is what we call the autologous hematopoietic stem cell bone marrow transplant. So if you are failing all of these drugs and patient cannot be given some drug like alemtuzumab, or we feel that the disease is very aggressive, there is an evolving evidence now strongly that autologous hematopoietic stem cell transplant is one of the methods of treating this disease with a near cure. I would say I am not really able to say that right now because follow-up data is there for 5 years, 10 years now. But these patients don't require any more disease-modifying treatments. So that's one up-the-ladder treatment which is currently also being done in patients who have failed more than 1 or 2 treatments and patient is still aggressive in the disease course. So this is how we go up the ladder, and you can reverse the ladder either way we want. This is a paper which was written by my friend and colleague Thomas Matthew from St. John's, Bangalore, recently published over there, their experience on using rituximab in MS, and they found very good results of this drug. So rituximab, and I'll touch down upon, I mean I won't have time, but I really don't know if I have time, but it's a CD20 blocker. If you look at the B cell lineage, there are markers CD19, CD20. It blocks those cells, and but it typically allows the normal function of the antibody formation in the body. So it does immunosuppress you, but not to the extent that you don't make normal antibodies. So they looked at their data and they found that with patients who got treatment, they really found that even in their RRMS patients and even in their progressive patients, they found benefit of rituximab. So if you look at ocrelizumab, which was approved for progressive MS, that also exactly works with the same, but there are different ways of making. Ocrelizumab is a humanized antibody. This is a chimeric antibody, rituximab. So that's the reason, it's not yet approved because there were not too many trials of rituximab, but clinical experience is very large with rituximab across the world. This is the way, the bone marrow transplant is done. I really don't need to explain you. But when we tell this to the patients and we explain them and they ask us, doctor, can I get a transplant? In the first event only they ask us. Obviously, that's not the right thing to do. So, you typically get admitted, you get, so this is a very standard paradigm, and recently there has been a change in the paradigm in which they are doing a very low intensity ablation. And with that low intensity ablation, there are hardly any adverse effects of the chemo, and they are able to perform bone marrow transplant much easily and with minimal mortality. So that's a new paradigm which is evolving. This is a data of hematopoietic stem cell transplant which clearly suggests, look at this pooled estimate, treatment related mortality has gone down to just about 2%. And in fact, patients who had a low intensity ablation, it is just 1%. So mortality is not very huge in patients of MS, and all benefits are clearly in one bigger population. Younger people, early MS, and relapsing remitting MS. The late the patient is and the progressive the patient is, the benefit of AHSCT is very, very uncertain. That's what you need to tell your patients as well. I will probably not do that. This is already I've explained. So this is also explained. This is the ocrelizumab which I was talking to you about, the progressive MS. This is a new thing in the last 4 years for residents. This is now an approved monoclonal antibody for primary progressive MS. We had no drug till 4 years back, 5 years back. Now we have an approved drug in these patients, but many of our patients, we even offer them rituximab because it works the same way. If we are picking them up early in the course of the disease. So about secondary progressive MS, and Vinay is here, he asked me to write this editorial a few years ago. Can we really treat secondary progressive MS? I think we can treat secondary progressive MS. The golden rule is that you have to pick up your patients early in the transition phase. Once they tell you that we are not doing well, you please follow them up very closely, because at that moment when they're actually starting to deteriorate, you have that small window of opportunity where the disease may still be active, that you can hit them hard with a more effective drug and lessen and stabilize the disease. When you have an established SPMS, it becomes a big challenge that you can do it. So a few years ago, this was a drug, siponimod, which was tried, and now we have an approved agent based on this approval of this agent to treat secondary progressive MS. It's currently not available in the country. It is an oral treatment which was tried and the results were benefit. The other thing is that if you are not doing well on a DMT, what would you do about switching? So there are these, you can use this small flowchart when you're looking at your patients in the clinic. And you can do this low, medium and high level of concern based on the relapse rates and the disability. Now to gauge disability, all of you will need to get practiced in doing EDSS score, which means that you examine your patients and you look at their disability in a formatted way, and EDSS should be mentioned on your follow-up cards. Unfortunately, I think it is not done by many people. So how are you going to gauge disability till you have formally examined a patient at every visit and pen down the EDSS score? If you're not doing it, that's not going to be a great thing to do. So based on the concern of relapses, progression and MRI, you can decide change if all three are low, two are medium, or relapse or disease progression is high. We use a typical clinical judgment in practice by checking on the relapse rates, MRI activity and patient stability. If I find any of these not doing well, I would definitely consider my patient to be switched to a more effective treatment. So that's something that you need to do. I'm going to switch. So I'll just finish up by this. I think this is the last slide. Yeah. So let's say you have a patient who has got diagnosis of MS. Your initial treatment can be oral dimethyl fumarate, teriflunomide. Generally in women with childbearing age group who are imminent to plan a pregnancy, we generally don't prefer teriflunomide too much because it stays in the system for a long time. And if a lady gets pregnant, you need to give them cholestyramine to get rid of the teriflunomide. So generally we don't prefer that, honestly. Dimethyl fumarate, I put this ocrelizumab, ofatumumab and rituximab also because we do not know if you will get an aggressive patient in the beginning. So you may get an aggressive patient also. And then you look at the patient's disease profile, and if patient is not doing well, you can make a switch between the drugs, or you can move to a larger level of better drugs, which is in India rituximab and presence of ocrelizumab or ofatumumab. Of course, what I would say, please look at disease activity, please look at EDSS, and please look at age, risk estimates, affordability and availability. All this needs to be in your pen down list, in your thought before you actually write a drug to the patient. And this is how you follow. If this is also causing a suboptimal effect, then of course you can consider strongly a possibility of a autologous bone marrow transplant in these patients. So on behalf of this, I just want to introduce that India now has its own international registry, and we were fortunate to get funding from Indian Council of Medical Research. This is called the IMSRN. I lead this registry, and we have very good colleagues from 27 pan-India sites with all major institutions now putting data into that. If you look at this, we have 1,818 patients till last 1 week. We have type of demyelinating disorders, which are MS largest. We get a lot of NMO and MOG data now into the system. And we also have other disorders. So hopefully in the next 1 or 2 years, we will have a more sizable, definitive data in different aspects from our country. So thank you very much, Atula, for giving me this opportunity.
Wonderful talk. It's great, and we could all understand and get few points. So at this point of time, I think it's ma'am would like to have, maybe you can have a break before your last talk. So I'll, sir, we can take it in the after his last talk, because actually, if it is a quick one, you please ask. You please ask. Yes, yes, no problem. Meanwhile, ma'am, if you can please come over and do your setup. I think ma'am wants to take probably. So, Professor Meena Gupta, over to you, ma'am.
पॉइंटर उसी का है या स्लाइड चेंजर ही है ना, तब तो अच्छा होगा ना, आई कैन मूव इट।
वो स्लाइड चेंजर
सकता ही है।
करेगा।
Can I have your slide to
It's already there.
Good afternoon. Again, you might find repetition, but a large quantum of patients coming to your outpatient and the emergency are suffering from primary headaches, rather majority. And the common ones are migraine, and relatively less common is cluster headache or the other tags that we are talking about. So again, I would emphasize on the history. The primary headache disorders that we are going to cover up now, we are already aware there are various types of migraines, and then the tension type headache, the trigeminal autonomic kephalalgias. Commonly amongst them is cluster headache, and then the stimulus evoked headaches, the physical activity, cough headache, excessive cold headache, etc. So I'll be mainly covering migraine and tags, the two of them. There are very few epidemiological studies from India, and there were few from Karnataka, then one from Kolkata, and now we have from Krishnan and Devashish, stating, you can see how common tension type headache is estimated. I mean, it's not exact, but it is estimated, and migraine, and then chronic daily headache, where we are majority of the headache patients who suffer from primary headache take drugs over the counter. Chemist सबसे बड़ा doctor होता है, and the chemist suggests, अच्छा headache की दवाई दे दो, so they keep on, and large majority take Ceridon. You have to see the components of Ceridon. They have been taking it for years. Or they might have one prescription, but they would take suggestion from the chemist. I think everybody must be having such kind of patients. A very small percentage visit the doctor for consultation. And these patients are seen by all physicians, all surgeons, everybody. The problem is so common. And every kind of specialist has seen these patients. So the quantum of the problem is so big. The primary headaches can be episodic, chronic. Chronic spells out a lot of trouble with aura or without aura in migraine. Then you have status migrainous, where the headache episode lasts for more than 72 hours. And then there are periodic escalations of headache in females. They might only have it during the periods, or they might have exacerbation of their headaches in the menstrual cycle, beginning 2 to 3 days prior to it, or during it, or even in the postictal 2 days phase. Then we have tension type headaches, which can be episodic and again chronic. Patient comes to you, मुझे 10 साल से रोज दर्द हो रहा है, या 1 साल से रोज दर्द हो रहा है, and it is so lucid and chronic. So they can also be episodic or chronic. Then we have trigeminal autonomic kephalalgias of various types. They can be lasting for half an hour to 180 minutes, or they can be only lasting for few minutes, occurring several times in a day, or they can be a hemicrania continua, that they start from one day, specifically they tend to remember, and then they continue for days on, or they again can be episodic. So, and the other stimulus evoked, I'll not be going into that detail. Again, take the history brings you to the probable, possible diagnosis. And I'm not going to repeat, we have already covered a lot on the history, but no amount of repetition is less or more. It has to be inquired in detail every time when we confront such a case coming to your outpatient or the emergency. Symptoms, again, this is what we have to inquire the preceding time that the patient might have had, what the patient was doing, how did it get. Usually among women we see that they want to finish the household work in the morning and then have breakfast, and bang comes the headache. So you need to take a thorough history as to how the headache had begun and how often it occurs, what time of the day, what time of the night if it is occurring at night or early morning. And again the relieving, aggravating factors and so on. And if at all, inquire about the comorbidities which might be there. Rohit mentioned about obesity. I just want to mention that obesity in migraineurs is very, very common. Obesity is coming like an epidemic amongst us. We are becoming couch potatoes and we have everything in our hands actually. पहले तो जाके आगे जाके चैनल चेंज करते थे, अब हाथ में ही है डिजिट उसका रिमोट. Everything is remote. We don't even have to walk. So obesity plays a very, very important role in the pathogenesis of headache as well. Mind you, obesity should be kept out of the door for each and every family, for each and every individual. And any other comorbidities associated like depression, anxiety, fibromyalgia is also a very common dustbin diagnosis, that it is part and parcel. When we don't know honestly to pinpoint a disorder, we might take the help of fibromyalgia. And many a times we have done this. We don't know what to, not as yet diagnosed or whatever, so we take the help of such vague disorders which might come to your assistance. And any endocrinal disorder, any drugs that one is taking for maybe cardiac disease which might be causing headaches. So we need to go into the drug history as well. And of course we examine the trigger points or the tender points or whatever limitations by a thorough neurological examination. The neck should always be examined. The trapezius should be palpated. The neck movements should be evaluated. Besides, of course, most of us have stopped examining the eye, the fundus. We refer the patient to the optho, especially in a busy practice. Please don't do that. We need to evaluate the fundus ourselves. We need to know what is happening in the brain before we investigate the patient. So, examine the patient thoroughly, and then we note if there are any red flags, because then you make another diagnosis. So any red flags which we have already pointed out, that acuteness of the pain, the change in the pain, the frequency, the intensity. Invariably migraine, if it is occurring for a long time, would tend to become more severe, more frequent, and more difficult to treat. So if there is any change in the pattern of headache, then that is another red flag. And postural link, etc. So this is just a repetition. Then we talk about migraine. Migraine is relatively a common disorder. Usually unilateral to begin with. It might start from the forehead or the temporals, and then 50-60% it may be only occurring on one side, or there may be changing sides as well. But significant percentage do tend to have a holocranial, throbbing, pulsatile headache as well. That increases on physical activity. That is very, very important. Going down the stairs, climbing the stairs increases the pain, or flexing, even while in females head washing might increase that pain. So it is very significant to inquire into these kind of symptoms. And then we know there would be an prodrome or a headache ictus, post ictus, and then interictal period. So you can divide, again, significant family history, and in adults, females are much more prone to develop such headaches compared to men. Then in the prodrome time, it may last for several hours, and there may be changes in the behavior, physical, concentration, yawning, irritation, lots of symptoms, vague symptoms can be there. So one has to inquire into the prodromal, and the patient should be made to perceive them, so that the patient knows that I am going to have an impending headache attack. And then we go on to the next phase. In certain individuals, there might be an aura. Have we come to the aura? No. In coordination. Fortunately, amongst Indians and Asians, the incidence of aura is much less. We tend to have the more common type of migraine in our patients compared to the West. And the aura commonly is visual, but it can be followed by another physical phenomena like paresthesias or pins and needles sensation in one half of the body. Or they can be, in certain individuals, change in the language or a speech pattern. There might be a subtle change. Again, the patient, if tends to have these recurrently, has insight that I am going to have the headache part. The visual aura would be positive to begin with, and it may be followed by the negative phenomena, that there may be a inability to see where there were scintillating lights or there were moving lights. Then there would be a dark area in those places, signifying the cortical spreading depression of Leo. That's how we explain it, that there is first hyperemia, where you are seeing the positivity, And then there is oligemia, where you are not able to see at all. And this progression would take place slowly, gradually, for 5 minutes or 6 minutes, and might continue for even 30 minutes. But this has to be distinguished from transient ischemic attacks or even focal seizures, where, or even occipital seizures, where to this cysticercus, which affects our population significantly, has a predisposition to the occipital lobe, and that occipital lobe seizures can also simulate in a similar manner, but they are much more rapid, and they might go on to motor phenomena as well. So the differential should be kept in mind, though those we all know epilepsy also has a post-ictal headache. We all know that epilepsy patient would be down and lying in bed for some time. So one has to thrash out the history and distinguish the differential diagnosis in this visual aura kind of a thing. But usually the migraine aura is pretty slow, stereotype, and this is followed. This may at times not be followed by headache. So that is called acephalgic migraine, where the headache is not there, but that is a small percentage. Fortunately, the aura part is not troubling our population to that extent. Hemiplegic migraine again is a very rare disorder, more familial than sporadic, and there is hemiparesis and various other symptoms associated with this repetitive phenomena. This slide is just to show the cortical spreading depression of Leo that occurs around 3 to 5 millimeters per minute. So it is so slow, and it covers from one cortical area to from the posterior part to the anterior part, and it doesn't follow any vascular territory. Now coming to the headache phase. The headache characteristics you all are very, very familiar: unilateral majority, throbbing, pulsating, exaggerated by physical activity. Associated symptoms are nausea, vomiting, phonophobia, photophobia, and then the duration. So earlier the headache pathogenesis was a vascular theory, but now it is a neurovascular theory, and predominantly there is excitation of the trigeminal nerve, the nociceptive receptors and whatever. So as you can appreciate, no pointer, no? That the trigeminal nerve is spinocranial going up, and it is supplying various, almost the whole of the scalp, the vessels, and that's how it gets triggered. There are environmental triggers or genetically, you are vulnerable to those triggers, and that's how the headache might start. And there is a lot of neurogenic inflammation. The CGRP, which is now being, and the antagonists, the receptor antagonists and the antibodies are being used for treatment of the resistant kind of or the frequent migraineurs, where you do not have other drugs to offer. So there is a lot of changes in the brain, and there are a lot of excitatory neurotransmitters coming out, glutamate, and that lead to a lot of discomfort and pain. CGRP, I don't have much to talk, but there are other serotonin abnormalities in migraine, and these abnormalities are again managed by triptans on 5-HT1B and D receptors, and lasmiditan, जो D-tans है, जो अभी mention हुआ था, that is acting on 5-HT1F as an agonist. So that is specific. These are specific developments to manage migraine pathogenesis and treatment. So migraine has made us cut off the duration of headache into two parts, more than 4 hours and less than 4 hours. It's very arbitrary. And migraine, to be labeled as migraine, one should have 5 such attacks of more than 4 hours. That would be accompanied by all these findings like unilateral headache, which is pulsatile, throbbing, and associated with either phonophobia or photophobia, or accompanied by nausea, vomiting. And these are diagnostic criteria for labeling the patient migraine, and which you have already tried with in the history. And then migraine with aura only needs 2 such attacks to be categorized as migraine with aura. Now coming to the point that various types of migraine are there, which can be episodic or chronic. Episodic, we all know that they are occurring in episodes, but the number is less than 14 days, that in a month. Whereas chronic is occurring for 15 days or more in a month, where you should have at least 8 such episodes, very characteristic of migraine. One has to realize that as the migraine becomes chronic, it loses its classical pattern of headache. It becomes a little more diffuse. It might not have those characteristic features that we have seen in the beginning. The chronicity changes, and the symptomatology also tends to change. So you need to really see the profile of the change, and then the response to treatment also needs to be taken into account before you diagnose this into a chronic migraine kind of a diagnosis. Now, how would you deal with managing such a patient? You have taken the history, you have highlighted or got information about the triggers. That trigger needs to be modified. One might not have one trigger, there might be multiple triggers. And all this history you might not get in one go. You might have to have repeated interviews with the patient in order to have this information, because the patient in the first interview may be so confused, so much not knowing what to answer, may not have even perceived. But when they reflect going back, then in the next meeting, if at all the patient comes to you, back to you, then the information might be there that these are my triggers, or one may keep on adding those triggers again more and more as we are making the patient more educated, more aware of what is really troubling the patient. So lifestyle interventions accordingly need to be done. Number 2, the sleep pattern, if it is not proper, erratic. Many of our youngsters nowadays have their own night and day. They might sleep at 3 a.m. in the morning, get up around 10. They might be working for multinationals, and they don't have that natural circadian rhythm. That natural circadian rhythm, if it is disturbed, it spells doom in the long run. You might have a lot of physical complaints. One might develop hypertension, diabetes, seizures, sleep-related problems, lots of them. So you need to emphasize and sensitize them that you are earning good, but be, inverted commas, be aware. So lifestyle sensitivity intervention needs to be done. That is very primary. Then of course managing the acute attack, being aware, and it's very important to emphasize that take the drug at the earliest. Don't wait for it to increase, having a cup of tea or coffee or doing some move around here or volley around here will help. No. Intercept right in the beginning and you will have the best result. That is the reason many a times we have drug failures, because we wait till the maximum impact of the drug or maximum impact of the headache is there. And then the drug doesn't work. The ordinary analgesics, over-the-counter analgesics, they don't tend to work. Then the triptans also, if you delay the intake of the drug, it's not going to help you as much. So you have to emphasize that take the drug at the earliest. And if one is having the prodrome, classical aura, you have to take the drug. If you delay it, you are going to have a partial response and there will be drug failure, one drug after the other, and then you will become chronic, which is very, very tough to treat. Then in certain individuals you might need preventive treatment, not in all, and the rescue treatment, when it fails you have other modalities as well. Lifestyle modifications, diet needs to be emphasized on, whatever. Only main thing is to lead a very disciplined, physically active life with regular adequate sleep, regular adequate meals, and that will keep your problem at bay. Be very careful to eliminate the triggers. Regular exercise, this is, we all know it, but we don't do it. A few words about the triggers. The triggers are very common and they might be multiple. So keep that into account. You are not the doer for your headache. You at least put them aside. If at all you can push them aside. Agar perfume se ho raha hai, agar smell se ho raha hai, don't use the perfume. Or बहुत homes में तो the perfumes are set aside. No perfume. It might trigger the headache or various pains and all that. So one needs to be very thorough in avoiding the triggers. Acute attack needs to be managed as early as possible. And it is cost effective. You can respond to simple drugs very simply, and that should be hammered into the patient and family, and not to decrease the dose. Last week there was a patient who was taking Naxtom half a tablet and not getting the response, maybe a 70 kg female. So repeatedly she was saying, I'm having a dull chronic headache. She has gone into chronic headaches. And I think Dr. Surana has already covered this. But now, this is from the literature. I have seen majority of the patients do tend to respond to simple analgesics. And then subsequently, we have to put certain patients on triptans. Nowadays, the ergot alkaloids are set aside. They have a lot of toxicity, but triptans also have a lot of toxicity or side effects in them. There is a lot of dependency on this ergot alkaloid. Vasograin addiction or dependency, I have seen many patients swallowing vasograin every day. So that is pretty harmful, but nowadays the ergots have taken a back seat. The simple analgesics, and of course added to them should be antiemetics, which further potentiate the effect of the analgesics. So primarily simple analgesics with antiemetics, and then you can step down to triptans, whatever is feasible. And then if the patient is resistant, of course there are many more offers, DTAN and GPANs. GPANs are expensive. They are expensive. They are not simply, I don't know whether the insurance covers them or not, must be covering. But this any new drug is expensive. And I'm stating off the record, any new drug which comes into the market, of course, is expensive. And it is the wonder drug. It is supposed to set aside all the previous drugs in the shadows. Gradually, when we work on it, then we realize what are the problems, what are the associated features. माने नया फैशन आने से पुराने फैशन कम नहीं हो जाते. There is provision for every drug, depends on the comorbidity of the patient or the physical problem of the patient that we are dealing with. So there might be the answer to our problems, but other drugs don't go into the shadows. They are commonly used, comfortably used, and we are very experienced in using them. So don't give them up. Many a times the patient is older, having a lot of comorbidities. We have a difficult problem at hand, and we can't give triptans to them. The comorbidities come in the way. So you have to depend on simpler drugs or the latest drugs because they don't have side effects so far. There's a lot of detail on these CGRP receptor antagonists, but actually they are better tolerated. I was just reviewing the literature. These drugs have not been compared to our routine drugs actually, and they are compared to the placebo in majority of these trials. So just take it with a pinch of salt, but they are seemingly promising. And the market trend is to give as expensive a drug as possible so that it weighs on the patient that I have to get better. The psyche may be this. So we have more new drugs coming up and they seem quite promising, but they have minimal side effects as well, and they might not be much of drug interaction. So they are pretty promising. Then coming to prevention. It all depends on how the migraine is playing in your life. If one has to take holidays, or the work is compromised, or the quality of work is not up to the mark, then one has to realize that this patient might be needing preventive treatment. And then according to the need of the patient, we prescribe the preventive treatment. Depending on any comorbidity, or the patient only wants to take one dose per night, or the patient is a little depressed, then accordingly we might, but we have to harp on the quality of improving the quality of life, the regular awakening, sleeping, eating, physically being active, and that might help in future. So that's what I think I have to say regarding migraine. And do not use any drug half-heartedly. Take the appropriate dose, and that too at the earliest. And then how preventive treatment is, of course, not for, removing the attacks or washing the patient off the attacks, but while preventive, the frequency would tend to come down, and also the intensity of the headache would also come down. So we are taking the patient away from chronicity by doing prevention. And we have to see whether we are dealing with a young female who is obese, so we'll prefer a drug which causes, fortunately, some weight loss and not weight gain. And look for, sensitize for side effects. Proper hydration should be there. So, or if the patient has got a tendency to have a calculus in the kidneys or the urinary tract, then one should not try to give topiramate, or any eye symptoms need to be looked into. There are lots of drugs depending on the need, the age, the gender, the comorbidity. We need to give the drug accordingly. There are certain monoclonal antibodies also in the scenario, and they also seem promising in resistant cases or in chronic cases. One tends to give once a month dose. They are injectable, and they don't have drug to drug interactions, so they are pretty, and some studies have been done in Asia, India also, and they have found that it is pretty effective in chronic cases as preventive. And more than 50-60% of patients benefited with this monoclonal antibodies. So there are various trials. I'm not going into the details of that. Coming to TACs, trigeminal autonomic cephalalgias. They occur in the distribution of ophthalmic division trigeminal nerve. They are accompanied by autonomic disturbances in the same area. The pain is excruciating and basically in the eye and the forehead, and they are side locked. So mind you, if you have a side locked headache, you must investigate that patient with imaging to rule out any secondary cause. The duration is very variable. Cluster headaches are the longest amongst them, and then one might have a short lasting unilateral headache for 1 to 2 minutes, 50-60 attacks in a day or even more. So that's what happens in various TACs. Clinical features are more or less the same. Duration, of course, is important, and it is important to diagnose the type of TAC because the treatment is different. Coming to the cluster headache. Cluster headache is also called suicidal. I mean, it's so bad. It's one of the severest kind of headaches. Unfortunately, it affects men more than women, and that too young males. The headache might start at night, maybe triggered by alcohol intake or some stimulants. The headache is very characteristic. Inside the eye, it's so excruciating. The eye becomes congested. There may be lacrimation. The eye might become small, ptotic. And the patient is extremely restless. So I just want to show this is a patient, 28-year-old, severe right-sided headache, and he is having very severe headaches, and you can see the gesture of that patient. It is so bad. He usually has these attacks while sleeping at about 1 a.m. This is classical of cluster headache, right? And these attacks last for 45 minutes. They are occurring several times in a day. This is another patient, 20-year-old, who has pain in the right periorbital, stabbing type of pain, several episodes, and they are short lasting. ये चल नहीं रहा. See the severity.
कभी यहाँ पे होता है ज्यादा ज्यादा के अंदर. हाँ आपके अंदर अब ज्यादा हो गया सर.
और आंख लाल हो जाती है.
हाँ हाँ
और
आंसू आ जाते हैं सर.
एक ही आंख से.
हाँ एक ही आंख
एक ही
से.
तरफ होता है.
हाँ
जो भी है इसी तरफ होता है.
जो भी है इधर सर.
कितने साल से हो रहा है?
सर यही 1-1.5 महीने से हो रहा है.
1-1.5 महीने से पहले नहीं होता?
नहीं नहीं कभी नहीं हुआ
एक बार होता है तो कितनी देर के लिए होता है?
सर. अब तो समझ लीजिए 3 मिनट के बाद होता है सर. यही 20-30 सेकेंड तक होगा. फिर मतलब रात भर सो नहीं पाता हूँ सर. इतना
कितनी दफा हो जाता है?
कम से कम तो 60-70 से ऊपर हो जाता है सर.
So you can appreciate the severity of such episodes. It's terrible. So these are called suicidal, cluster headaches are called suicidal headaches. They are so bad. And they are occurring in the active phase of life, in the active periods. There is a classical diagnostic criteria as per the guideline, and headache accompanied by at least ipsilateral conjunctival injection, ipsilateral nasal congestion, eyelid edema, ipsilateral forehead and facial sweating, ipsilateral meiosis and ptosis, and a sense of restlessness. That's very important. The migraineurs are quiet, they want to lie down peacefully in a dark room. These patients are agitated, they are restless, they can't lie in bed peacefully. And there is a pathology in the, of course, the trigeminal system, as well as in the posterior hypothalamus. That is supposed to be the genesis of this problem. CGRP again is supposed to be responsible for this activity. And the medications have already been highlighted by Dr. Surana. 100% oxygen is very effective, and 5 to 7 liters per minute, or some patients might even need much more oxygen than 5 to 7 liters per minute. This should be given for 15 minutes and then stopped. It can be given in various number of times. And then we have triptans, subcutaneously sumatriptan or zolmitriptan, also nasal spray. We have a drug, new drug, galcanezumab, also, which tends to prevent episodic cluster headaches. That's it. Then the preventive part, verapamil, again needs to be monitored. It has to be titrated slowly, so that one has to look for arrhythmias or any cardiac rhythm disorders. And verapamil takes some time to be effective. So during that period, we can have a bridging therapy like GON block, greater occipital nerve block, so that the patient has relief for some time. And or one can give lithium. They all have a lot of side effects, so one has to be very careful. Lithium has to be, levels have to be monitored, and lithium has its many side effects, so one has to be very careful. Tremors, encephalopathy, like things, one needs to take that into cognizance. Steroids again as a bridging therapy to give relief to the patient immediately, which can be rapidly tapered as the patient is having relief. And the injectable ergot alkaloids, or not the injectable, the oral, that is the lowest in the list. That also is found to be effective. Then the other paroxysmal hemicranias. They are responsive to dramatic response to indomethacin. So if you have diagnosed the condition hemicrania continua or episodic, one has to really prescribe indomethacin, start low and gradually titrate it. You might have to give some GI settlers, proton pump drugs, so that the patient does not have any toxicity, and the response is excellent. You might be categorized in the category of God if the patient gets relief immediately. And then indomethacin, of course, has to be given, and it can be escalated. And then we tend to, as the patient gains confidence and is asymptomatic for a few months, one can start tapering the drug. It has lots of side effects. And then we come to SUNCT, the short-lasting neuralgiform attacks with conjunctival injection and tearing. Again, these attacks are very troublesome, autonomic features, lacrimation, and more in females. They tend to not really respond well to indomethacin, but they tend to respond to your anti-epileptic drugs more often. So one has to make a proper diagnosis and treat them. But mind you, they all should be investigated thoroughly. Because there might be a secondary cause, like aneurysm, like dissection, like any structural pathology in the pituitary. Trigeminal neuralgia has to be differentiated from them, and primary stabbing headache, lots. So one needs to rule out the secondary causes. Just a few words about primary thunderclap headache. We had mentioned that subarachnoid bleed or many other disorders of the brain would be preceded and accompanied by thunderclap headache. But in a very small percentage of patients, one might see primary thunderclap headache. And this primary thunderclap headache may also be a feature of headache in the migraine patients at times. So this is fairly uncommon, but again one has to rule out a secondary cause in this setting. A few words about tension type headache, which we most often don't see. And this is a dull headache, band-like sensation, mild to moderate in the visual verbal scale of pain. And the patient devises methods to counter it. There may be pericranial tenderness or no pericranial tenderness associated with it. And there are diagnostic features prescribed in the ICHD-3 classification of headache, that it is bilateral in distribution, pressing, tightening quality, non-pulsatile, not aggravated by physical activity, no nausea, vomiting, may have phonophobia or photophobia. But again, when the chronic part starts, the distinction between chronic migraine and tension type headache becomes very grey. So one has to take the background history into account. And the treatment is, again, abort the treatment with simple analgesics, and not to overuse the headache, nip it in the bud, that is important. Non-pharmacological treatment is very important. If there are comorbidities, kindly manage them. And lead a regulated life as much as possible. Tricyclic antidepressants also contribute to the management, or any other antidepressant depending on the comorbidity of the patient. So the management part is that we need to diagnose the problem by virtue of taking a detailed history. Most of the patients are migraineurs visiting your outpatient. Medication history needs to be taken into account, so at the outset you never get, but if you sensitize the patient, patient might be forthcoming in the next few interviews, and manage the migraine at the earliest as possible. When the episode is starting, kindly be aggressive, and that needs to be instilled in the patient. Patient participation in the management is extremely important for your success and for the patient's success. Make the patient make a headache diary where one can detail out the episode, the triggers, the prodrome, the aura, the ictus, if at all the aura is there, the ictus, the relieving factors, and the patient should be made responsible for their improvement. Empower the patient to really be in control of their headaches. That is the most important thing, that you can educate the patient and make the patient participate in the management of his or her welfare. That is the most important thing that you can inculcate in the patient, and just insist on making the headache diary in detail. ये नहीं लिखा होना चाहिए इस डेट को हेडेक हुआ. No, it is just to sensitize and make the patient in charge, responsible for their own betterment, for their own vulnerability, right? And take the history of the drug history into account. That is extremely important. Thank you for your patient hearing.
Thank you very much, ma'am, for giving us extensive insight into headache. Probably since we are already out of time, so we'll be going to our last session. This is about movement disorder, Parkinson disease, deep brain stimulation. I think it's been kind generosity of Dr. Vinay Goyal, who is our own, from Udaipur. Sir, he's been a professor in All India Institute of Medical Sciences. He's president of Movement Disorder Society of India. He's member of Multiple Sclerosis Society of India. He has been holding various posts in neurological, associations, and he is a great academician, and he has many national and international publications to his credit. So I think I'll hand over podium to him. Till the time the laptop is set, you can start, sir, without PPT also.
Thank you, Dr. Atlab. It's always a pleasure to be back in Udaipur, especially when I see my teachers sitting in the audience. I was very happy to see Bam Saab, Jen Saab, and some of my old friends. My parents live here, so I always have a reason to come back again and again. So every invitation is welcomed. And my colleague, Dr. Rohit, had to catch a flight, so he couldn't finish his talk and he has to go. Dr. Meena Gupta also has to catch a flight now. I was assigned 4 lectures, which is actually a difficult task. So what I thought was I'll take 3 of them. And a topic given to me are advances in Parkinson's disease. So I'm not going to talk about the routine management of Parkinson's disease, because I see there are a lot of students. I would love to talk that talk rather than advances in Parkinson's disease. So there is a reason to call me again here. So any Sunday I could come here and take a talk on management of Parkinson's disease. I think I've done this earlier also. And if all youngsters who are sitting here, they want to ask any question anytime in between, please stand up and ask me. So don't hesitate to ask me. इसको क्या कहते हैं? ठीक है. I bring greetings from Vedanta, which is my current affiliation. So this is the first paper which was published by James Parkinson. He described 6 cases, and what he described as a shaking palsy. I'll tell you how significant or important was to call it a shaking palsy. You know, you're shaking and you're palsy, how it is possible? If you're shaking, how you could be paralyzed? So something like that. And these are classical symptoms, rest tremor, which are usually starting with asymmetrically onset. Asymmetry is a classic feature of Parkinson. It is not mandatory that all atypical Parkinson are not asymmetric, but if you have asymmetrical syndrome and rest tremor, take it as a thing that it is Parkinson. Always look at my hand. If there is something, you know, pill rolling tremor, which are very classic of Parkinson. So look at the rest tremor, bradykinesia, slowness of movement, rigidity. When you move the arm for the reason, if you want to check the rigidity, hold the hand like a shaking hand and then move it gently. Don't move it fast. Or rotate the wrist. When you rotate, if there is a cogwheel is rigidity plus tremor. So you will be able to feel the jerk. That will help you to decide. Posterior instability, we all know it is a little late feature. So what I am going to talk is what are advances in diagnosis, what are advances in medical management, and what are advances in surgical thing. So what are advances in diagnosis non-motor symptom? I'm sure all of you know it now because it's not a new topic to talk about, and little about imaging. So what are the non-motor symptoms? When I was undergraduate or when we were doing PG, we never thought about it. That these are symptoms of Parkinson. We thought they are associated symptoms. But when you know this non-motor symptom can predate by many, many years. And so this is like so what you see as a Parkinson as the first beginning, it's like a tip of iceberg. So the 90% of the symptom which is happening here is below the sea level, what you call as non-motor symptoms. Look at this chart. By the time you have the first motor symptom, only 80% of Nagel cells are dead. So the connotation is also that all the trials which are done to as a neuroprotective drugs, if in a disease you already lost 80% of cells, what kind of neuroprotective drug will be useful or positive? That's the reason all the drugs, all the trial methods which people have tried, they have failed. So now the issue is, can we diagnose Parkinson before they develop a motor symptom? So, which is another debate about it. So, they predate. There are patients don't usually complain about. I give you a simple example. Constipation. Who will come and tell you I got a constipation, I will develop Parkinson? So the Honolulu study said there are 4 times higher chances of developing neurodegenerative disorders. And Alzheimer's and Parkinson are classic one of the examples. Even doctor won't ask you. If you have somebody will go to constipation, you might have Parkinson. So then you have 4 major symptoms you should ask for. If you have a patient, you think this is a Parkinson, 4 important points. Constipation, RBD, REM behavior disorder. So ask the spouse, is he getting up in the night and shouting or kicking or moving limbs or playing something like that? Third is hypotension, postural hypotension or the autonomic features. And fourth is smell sensation, anosmia, which is quite some of them would tell you that recently for the last 4 or 5 years my smell sensation has gone down. So in a given setting where you think this is a Parkinsonian syndrome, which you are not sure is Parkinson, if you have these 4 motor symptoms which can predate up to 20 years, so that symptom will tell you this is more likely degenerative thing. So in one of the studies, about 62% of non-motor symptoms of Parkinson remain undeclared. Nobody is asking them. This is a big study of UK, which patients were taken as the UK Brain Bank as a criteria to diagnose Parkinson. How it was developed, they looked at the brains of the patient with definite Parkinson. And then they looked back and decided what are the criteria, and I'm sure you can read about UK Brain Bank criteria. So this is a 433 patient study. 21% of the patients, the first manifestation were non-motor symptom, which usually we ignore. Common and neuropsychiatric, 16 to 70% depending on the stage. Cognitive involvement. Normally when I see a patient with Parkinson, I don't expect a cognitive involvement. But if you assess clinically, then they may have what you call it PDD, Parkinson Disease Dementia Complex, which can develop usually later on. Sleep disturbance, as I mentioned about, the classic is REM behavior disorder There are a lot of other sleep disturbances which you can talk about later on. And dysautonomia, constipation being one of the most important factors. Always ask about constipation in this patient. So this is the Barak hypothesis. What they did, they looked at the histology from various stages, and this is a very popular study. So as you could see from here, your symptom may start, so Barak staging in Parkinson may start 20 years before. When you have no symptoms of, so when you look at the histology, they have histology of Parkinson, but the symptoms are not motor, they are non-motor symptoms. So this is the staging, so I think I can cut it short. So there are 6 stages which is described, and symptom may match from starting from the mesenteric. So constipation is one of the earliest symptoms, as we know. So to remember non-motor symptoms, this is my eponym. You can remember abscess. What is abscess? A for autonomic dysfunction. So constipation is one of the classic example. Behavior issues, cognitive impairment. As for sleep dysfunction, RBD, and sensory pain is an important symptom. One can remember that. Let's talk about imaging. I'm sure all of you know F-Dopamine scan, which is a very sensitive scan, and currently is available in almost 10 cities around the country. But there is a problem. Every F-Dopamine scan which is doing is not that reliable. So best example is when patient comes to me with a very early Parkinson, and clinically when I'm doubting, is it Parkinson? The report will come severe decrease in uptake. How it can be possible? I'm doubting the diagnosis and you are giving me a report of this. So quite large number of people who come to me with this F-Dopamine scan, I really look into the patient first and the scan later on. Today only I saw a patient has genetically proven SCA12, but F-Dopamine scan is positive. How it is possible that you have F-Dopamine is positive genetically proven case which is SCA12? Recently I saw a patient which improved on lumbar puncture with NPH, but F-Dopamine scan was positive. So false positivity also is coming very high. So this, as you could see, the dopamine uptake is gradually going down or as it gets severe. Other is MIBG scan. So MIBG scan will be important to diagnose Parkinson. So it can differentiate from Parkinson from atypical Parkinson. When I say atypical Parkinson, it means PSP, MSA, CBD, secondary, and all other Parkinson. Diffuse Lewy body dementia, pure autonomic dysfunction because they have a sympathetic denervation, and that's lead to MIBG scan abnormality. And familial PD and SNC duplication disorders. This is again, as you could see from here, and this is a normal scan. This is a Parkinson with autonomic dysfunction. As you could see, it's gradually decreasing. What is change in MRI? So this is a little old scan. This is a 7 Tesla MR, which is currently is into more of a research tool. It's not available in India. It's not available for practice. But what you could see, if you look at the substantia nigra, you could see the serrations. The border is not clear anymore. So by imaging quality, you can diagnose that this is so. And we are not doing an expensive test. It is a basic MRI you could do and look into it. There are a lot of other MRI signs that you get swallow sign, but all those signs are so difficult to see and they are difficult to rely on. What are sweats? For students, what I was saying, so when Dr. Fan was doing a L-Dopamine study. What was L-Dopamine study? L-Dopamine study was, when I was a senior agent, I was doing my MD, there was a paper published in 1991 which said levodopa is toxic to brain or toxic to neurons. Why? Levodopa increases oxidization and that leads to more neurodegeneration. So that was a hypothetical basis. And animal experiment has shown this. But it took almost, in 2005, Stanley Fan published L-Dopa study, which was to look into whether the levodopa is more toxic to neuron. Hypothesis is, so if I give a levodopa to one group of patients and don't give to another group of patients and follow them up, over the period of time, patients who were given levodopa, they should have more faster degeneration as compared to the patients who were not given it. So this was a 52-week trial, and when they did it, they saw, and they also did beta CIT SPECT, which is also kind of a dopamine uptake marker. Clinically, and after 52 weeks, they watched for 4 weeks, the group which was levodopa, so both the group was parallel now, they're off the drugs. And they compared the UPDRS is a scoring system of severity of Parkinson, and they looked at the scores. So expectation was patients who were on levodopa, they were a higher increase in the score, but it didn't happen so. The reason, this is called trial design. Nobody looked at how long the levodopa effect lasts. So can anybody tell me what is half-life of levodopa? Sir, आपको नहीं. पीछे बहुत सारे बच्चे बैठे. Point is, half-life is only 3 hours. But when you stop the drug, the effect doesn't go in 4 weeks. That was the reason for the failure of the trial. It didn't show the difference. If they would have planned this at 8 weeks, that might have shown a clinical difference. But beta CIT spec showed more degeneration in levodopa group. So this is still a debatable thing. So that changed the practice, because when we were taught, we were told that don't use levodopa at the beginning. Spare it for eternity, as if we are going to use it for next 200 years. But now, use it as liberally as you can. To criteria, if the patient has disabling symptoms, please use levodopa. It has been shown that patients who don't treat themselves well at the beginning, the outcome or the disability over the period of time is more. And I see this very often. And most of these patients are doctors. Because उनको पता है levodopa is toxic. तो खाते नहीं दवा. And they become miserable. And some of my patients in next 15 years become bedbound. So they have not done well. So what is SWADS? When they did this L-DOPA study, they found that some of the patients, there were no evidence of dopamine uptake. So there were no deficiency. What you call SWAD scans without evidence of dopamine deficiency. So they look like Parkinson, but clinically, but that scan didn't show that. So sometimes if you follow these patients over the period of time, they don't worsen that much. They look like, I see sometimes patients that they look like Parkinson. When I do that scan, it's normal. They come back to me later on, they remain almost same, or there is minimal deterioration, which there are hundreds of reasons somebody could be Parkinsonian. So what are advances in medicine? Dopa agonists, I'm going to talk about. Apomorphine, which all of you must have seen videos all around, and recently, last 2 weeks, the same videos have resurfaced. As if some magic has happened again, so we'll talk about it. Duodopa is a gel, and levodopa. I'm going to only talk about 4 things. So when we talk about dopa agonist, rotigotine patch is something new. This rotigotine patch came to India twice. They did trials, but because the patch was unstable because of the ambient temperature, people sweat a lot, and the molecule was not releasing it well. So it has failed. I've used in some of my patients who used to bring it from abroad. It is a good drug because you put one patch and it works for 24 hours. That's the only advantage of this. So this is something like a patch, you put it and it works. The problem is you require at least 12 to 15 milligram patch per day. And one patch, when I inquired at some point of time, was costing 500 rupees a patch. So it's something like 2,000-3,000 rupees per day cost. If somebody can afford it, it's fine. So as you could see from this, 13.5 milligram and above dose was most effective. Below that, the efficacy was not very good. Now, I kept voluntarily this slide that which dopa agonist to use. Pramipexole, ropinirole. So pramipexole versus placebo without levodopa, as you could see, improvement in UPDRS was 24% versus 4%, so there is no doubt about it. Pergolide, which we don't use, the efficacy was 35%, and ropinirole was so currently pramipexole and ropinirole, there are 2 drugs available. So efficacy is 27% versus 22%, almost same efficacy. So it is an individual choice. So what is the difference? Ropinirole is a cheaper drug, but what is the target dose? Is 24 milligram per day. So you have to, and I'm sure none of us have used 24 milligram per day. We go 4 milligram, 6 milligram, 8 milligram, then we stop it. I have used up to 20 milligram. So you have to take so many number of tablets, which is the only reason is the cheaper drug, ultimately cost becomes same. Pramipexole is a longer acting drug. You can go up to 4.5 milligram, and beyond 4.5 milligram, if you increase the efficacy is not there. But you're unnecessarily increasing the cost of the drug. So 4.5 milligram is good enough. This is a wonderful chart, and you must understand this. this is a wonderful chart to understand the management of Parkinson's disease. And if you look at the chart, the middle line, in the red middle line, is a drug level, which we are ideally want. So when you give the drug, if the drug level remains like this, we would not have been discussing Parkinson here. But fortunately, unfortunately, it doesn't happen. So when you give the drug level varies like this. Over the period of time, because of the post-receptor susceptibility, the drug level remains same, but the receptor susceptibility changes. What is therapeutic index? Therapeutic index is, so this white line is therapeutic index. It means if your drug level is between the therapeutic index, you will have best effect. If your drug level will go below this, you will have off phenomena. If your drug level will go above this, you will have on phenomena or dyskinesia or side effect of the drug. As you could see from here, over the period of time, the therapeutic index goes down. It becomes narrow. That is because of the mechanism which I was telling you. So down 5 years, as you could see, sometime when you give those same dosage, same timing, the drug level will go up. That will cause dyskinesia. Then after 2 hours, the drug level will go down. Patient will be off. As you could see here, barely the drug level is useful now. Either it is up or down, which is called yo-yo phenomena. Either you get off or dyskinesia, off or dyskinesia. So that's a situation you have to do something, because this levodopa dosing is not working anymore. So what they did, this is called continuous dopaminergic stimulation. What is that? To do that, you have a gel pack. This is a gel pack. And this is a machine. So there is a diagram. Yes. So you do a pack. You can't put a nasogastric tube for many years. So you do a pack and you connect this machine with this pack. And you can titrate the dose, how many milligram per minute it will go, and it can run 24 hours. Or if you want to save the drug, you can switch it off in the night. That sounds very good, isn't it? So the solution, the problem of Parkinson is here. You do duodopa and you are free forever. But that is not true actually. The problem comes with this mechanism. The tube will block, there will be infection, there will be overgrown, it will leak out. So mechanical complication is one thing which prevents this. Second, cost. Some 10 years ago when this company came to India and when I talked them the cost, that time after putting the pack, the cost was 2 lakh rupees per month. And I'm sure in 10 years it must have been 2 lakh because the number of patients have remarkably increased. But currently it is not available in India. I was in Dubai last month and they are using it regularly. So look at the evidence. So this is a 7-year experience with gel. These are 59 patients, and duodopa improved motor functions, and over 90% of the patients reported improvement in their quality of life, which is a good thing. When you should do, I will talk about DBS, my next talk will be on DBS. So DBS is another good choice. The debate is between duodopa and DBS, which is an ongoing debate all the time. Some countries which don't approve DBS, they may do duodopa. Some patient doesn't want to fiddle around his brain, then he will go for gel. So as you could see from here, the quality of the next, but the problem is gait improvement was in 54%, but the worsening in 5%. Dysphagia and dysarthria improved in 33 and 80%. So axial symptoms don't improve even with levodopa. As we know, in Parkinson patients, whatever you do, axial symptoms are difficult to improve. So at about 25.8 plus minus 19 for 5 months follow-up period, as you could see, total score which was baseline was 8.5, it improved to 5.7, which was significant. And dyskinesia duration improved, dyskinesia disability improved, dyskinesia pain improved. Off stays also improved. So all the symptoms of Parkinson related improved. Let's talk about apomorphine. So how many of you know about apomorphine? Really? You don't know apomorphine? There's so many videos are going around. So some 3 years ago there was a big uproar about apomorphine. There's a magic drug and it will cure it and you will be fine in 6 minutes, which video claimed. And so, so what happens when you disease increasing, the stage will come. Sometimes there are no on phenomena. In spite of taking the drug, you don't get on. Second is sudden off. You have taken the medicine, you are in the middle of something, you will go off. So these two situations where you are either no on phenomena after taking the drug or you get completely off suddenly. They are unpredictable things. So life becomes very unpredictable. That's where so either you, one thing is you can take Syndupa tablet, crush it, dissolve it into, put water, and if you want to keep the liquid for longer period of time, you can add vitamin C for more stability and keep taking sip, which is like gel. We are going through the tube, now we are taking drip. So सारे दिन आप एक एक घूंट पीते रहो. कभी ज़्यादा पी लिया तो दिक्कत हो जाएगी. खाना खा लिया तो दिक्कत हो जाएगी. Because food interferes with the absorption of levodopa. Levodopa is an amino acid. So for all those patients who are taking levodopa, it should be 1 hour before, 1 hour after empty stomach for the best absorption. And studies have shown if you take with protein or food, up to 1/3 of the dose may get wasted. And I would tell you about 60% of patients who come to me, the only magic I do is change the schedule. A bigger problem. Levodopa, what time you should take? सुबह दोपहर रात को? एक सुबह खाया, एक दोपहर रात को नहीं, क्यों? रात को क्यों नहीं? Speak loudly. नहीं. It is yes as well as no. Yes, because levodopa is like a petrol. When you need levodopa when you want to walk. So you take first dose in the morning as early as possible, second after 4 hours, and third after 4 hours. So 6, 11, 4. It will 4 to 5 hours. It will cover the day. When you take 5 o'clock or 4 o'clock, it will go up to 9 o'clock. So what is the indication of giving levodopa in the night? One is early morning, but levodopa won't last up to the early morning. Bigger reason is when the patient finds difficulty in turning in the bed. रात में पेशाब के लिए उठना पड़ता है, वो ऑफ हो जाता है. That becomes a problem. Then you can give long acting CR preparation. CR preparation currently is available in 2 denominations, 125 milligram and 250 milligram. So if 125 milligram is not available, can you break 250 milligram and give it half? CR preparation is coating. It's not particle coated. So when you break it, it becomes normal. So don't do that. And I see it very often. I write 125 milligram, they buy 250 milligram, break it and take it half. So that loses the potency. So apomorphine can be given by 2 methods. Either there is an insulin-like pen. So it's a rescue. You keep your pen with you. If whenever you get off, anywhere in the body, you punch it and punch the dose as much as you have to titrate it. So to decide this, you have to see these patients when you are doing titrating. Biggest problem is vomiting and hypotension with this drug. So 2 things you have to check. Do Coombs test because it can cause hemolytic anemia. So before giving this basic test should be done. And ECG to look for QT time. So when you giving levodopa, they can punch it and deliver that much amount of drug, and that will take care of it. Effect will come in about 2 to 3 minutes, but effect will last only 5 to 10 minutes. It's not a longer thing. So it is a rescue medicine. A lot of patients I get 4 times off, and I get very terribly off. When I take my next drug, it takes time to get on. That's the patient in for apomorphine. Or those who are unpredictable off, मेरा कहीं भी off हो जाता है, so they can keep the pen, punch it themselves. Other method is to use this pump. So pump will, there is a needle, you can prick it in the stomach. Every day you will have to do this. That's the problem. And then program that pump and it will go continuously release the drug. So you can do it in the day, night time or 24 hours. This is the syringe and this is the pump. Toledo study was the biggest study published for this, which are 106 patients with advanced Parkinson's disease. And at 12 weeks, apomorphine group had reduction of off time by 2.4 hours as compared to 0.5 hours. So it was a significant reduction in off time. Another is inhalational levodopa, which is not available in India. It is available in very few countries. So it is like a salbutamol pump. You can inhale the drug. It delivers dose of 24 milligram per capsule. This is the study which was published in 2019. I'll just cut it off. So what is the advantage or disadvantage of this? Let's talk about that. We know it works. There is no problem with that. So what are the problems with oral levodopa? Motor complication, as I mentioned to you, because you take a large amount of drug. Inconsistent or delayed drug delivery, because when you take the drug, initially it will take about 15 minutes to on. In advanced Parkinson, it may take up to 1 hour. So you need something different to do. Food, as I mentioned, food is dependent on food intake, affected by dysphagia and other GI symptoms. So if you have higher GI motility, it will change. Patients of Parkinson have severe constipation. If you're constipated, your drug absorption will change. So all these factors will change every drug effect. So it will impact the basically drug absorption and peripheral metabolism. What are the advantage? It rapidly gets absorbed because the moment you inhale, it starts working. It's intermittent on, as I mentioned, you can take it in off period of time. Plasma levodopa concentration increase more rapidly. So we are giving 42 milligram, only almost half of the drug what we give routinely. So small drug, so it doesn't give a peak. Dry powder formulation administered by breath accentuation is something like what we've been doing for asthma. What is the problem? Yes, disadvantages. Requires drug formulation and delivery system that can be reproducibly or conveniently administered. The treatment relatively larger doses are required. So sometimes one puff will not work, then you have to take second puff, then third puff. So that's the problem. So puff, and then every time the puff dosing will change, and you have to take it intermittent. So it is more inconvenient. For SOS is fine, like I mentioned, apomorphine. So when given a choice, you can take apomorphine tablet is also available in India with 2 milligram denomination, and it is a sublingual tablet. I have tried, but it causes a lot of nausea and vomiting, so I don't use it anymore. What are the other advantages? Surgical management. I'm going to discuss only deep brain stimulation right now. What is the evidence and how early it can be done? With randomized trial, it has been well proven that DBS works in Parkinson's. There is no doubt about it. So I'm talking beyond that. So this was the early STEAM trial published in 2013. What was the early STEAM trial? There were 251 patients, and they had disease duration of 7.5 years. Normally all the trial were then there were 8 to 10 years of disease duration by the time they were doing it. As you could see from here, there was significant improvement in the patient group who were treated with DBS as compared to best medical treatment. That shows the efficacy of. Look at the important factor. What is the important factor here? Okay, the slide is gone. The biggest advantage of this study was that there was significant decrease in levodopa intake. So the group which was underwent DBS as compared to patient who was the best medical treatment, the levodopa, as you could see here, the 609 milligram of levodopa was reduced. And patient who underwent this as compared to some 56 milligram. So that's the evidence from the study. Problem is, when people thought, when you are doing early, why not to do even early? So in 2012, Professor Charles published this protocol. This was a patients of 30 patients who went underwent DBS within 2 years of onset of diagnosis. And when they published this, and 24 patients completed this 2-year study, and a 2-year follow-up study. When the 24 months data was published, as you could see from here, most of the factors which was HNER, Schwab scale, UPDRS, on time, off time, there were no difference between medical and surgical treatment. So what is the advantage of doing early DBS? Advantage was there were a levodopa increase in 2 years was 97 milligram in patient who underwent DBS as compared to 240 milligrams. So almost more than 50% reduction in drug requirement. That is the advantage. One more thing. There is a hypothesis which has not been proven now that if you do like this, and this DBS might be neuroprotective. For neuroprotective, maybe when they will have 10-year follow-up data, then we will be able to say this. Then we will be able to see that doing early DBS is more neuroprotective, or the disease degradation is smaller as compared to best medical treatment. But currently we do not have the data right now. As hypothesized, the mean UPDRS total score and part 3 score were not significantly different in this therapy. And then there are a lot of, once the trial is showing a data like that, then they look at the cognition, they do look at the gait, they look at the swelling. So there are multiple papers which have been published. But the point of carry home message from here is, at 2 years, both the therapies are equally effective. Now the question is, what is the debate? How sure you are that it is Parkinson at 2 years of age? You may make a wrong diagnosis and end up putting a lead in the brain. That is one thing. Second thing, it may be atypical Parkinson. So it turned out to be MSA, or it may turn out to be PSP down 5 years or 10 years. So you are doing a wrong surgery. So now the question should be, what's wrong if you do DBS in PSP and MSA? Isn't it? With the same Parkinsonian syndrome, you could do DBS in them. But it's been well proven that atypical Parkinson, when you do DBS, they don't do well. Rather, they deteriorate faster. So atypical Parkinson is absolute contraindication to DBS currently. Now the second question comes with which nucleus to use, Subthalamic nucleus and GPI are wonderful two sites currently we know of which work well in Parkinson's disease. So this is the NAPTA study which was published in 2013. They had 5 centers. The primary outcome was functional health by academic medical center linear disability scale and composite score of cognition, mood and behavior at 1 year follow-up surgery. They had 128 patients, and when they looked at 1 year follow-up study, this ADLS score was not different between the two groups. So whether you use GPI or use STN, both are equally efficacious. And the composite score also did not change. But what was the change? Again, the patient who underwent DBS, STN, the significant reduction in levodopa as compared to GPI. I think in my another talk, I'm going to talk about which are the patients for GPI and which are the patients for STN. So current understanding is most of the places around the world, they use STN as one of the target. There are some centers, it's kind of a tradition. Some centers started doing GPI, so they think GPI is good and they keep on doing GPI. But most of the centers around the world do use STN as one of the centers now. So let's look at how do you do DBS. This is a very old video just to explain how you do DBS. So you put a stereotactic frame. This is a 1 minute video. You do an MRI, and after doing an MRI, so you first an localization by MRI. So you localize SCN is 2 millimeter by 6 millimeter, it's such a small nucleus, a very small nucleus. Then you put a micro electrode in the brain, which are 0.27 millimeters thick, thin wires, very thin wires. And initially we used to put 5 grid into the brain and record areas, but now we don't do that. We put only 2 electrodes. And this is the recording which if you can see very well. The upper one is subthalamic nucleus. If you go down, this is called substantia nigra. So you could see the cell difference between the two. This is a single cell recording. So a very sophisticated thing. So from this cell recording, you are sure you are in STN. So physiologically, you are in STN. Then what you do intraoperatively, you stimulate the nucleus and look at tone and bradykinesia. So clinically also you can be sure that patient is doing well. So the 3 ways you can make sure the patient is done well for the surgery, and then you can program it. So let's look at one video. I'll stop this video in between if it works. James Parkinson must have seen patient like this. So this is called shaking palsy. He's shaking, but look at him. Can he move? He can't move. So he must have seen a patient like that. So somebody is pushing. Dr. Lazar is my very old resident, so he's pushing him. So let's look at him. This is off stage, so he has significant tremor, and we'll look at him shortly. When he's sitting, 2 of his sons have taken off the job, and they were looking after his father all the time. And this is post-operative. He's quiet, there are no tremors, and shortly you will see him walking in the ward. He's walking so well. So sometimes it's so gratifying. This patient taught 2 lessons to me. One, the patient became maniac after surgery. On the table he said, I'm very fine, I'm absolutely fine. I don't own wheelchair, I'll walk down. And from OT to the ward he walked down. He became maniac. So it was a transient effect. So mania is a common complication, not common, uncommon complications which can happen immediately after surgery. And he walked down the ward, and when the drug effect went down, because when you do surgery, he's off the drug. Just imagine the way he was off the drug and he could walk down from the OT. So he did so well. Another rare complication which you can read my paper. So what happened, this patient started perspiring while doing the surgery. So I asked my anesthetist, why is perspiring? He said, BP is fine. And I don't know why I auscultated him. And this is one of the most weird sound I have ever heard in my life. What was that? This is called windmill murmur. Does anybody know what is windmill murmur? So windmill murmur, you take a cup of water, put a windmill and move it. The sound will be sarala, 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 sarala. So from the brain, it got trapped the air and it went into the cardiac chamber. And that's why his cardiac output decreased and he was sweating. And within few minutes, when I again auscultated, this murmur is gone. When I talk to my anesthetists, they say people don't hear this murmur in life. So it was an extremely rare phenomena he had when we were operating, and fortunately he improved. Let's look at this patient. So tell me, is this a patient of Parkinson or not? You should play. Oh no. My videos are very old like me, and sometimes they don't work. I'm sorry for this. Correct. So I'll play it here if it works. Is it a patient of Parkinson's disease? Yes or no? Yes, sure. Oh. सर मेरे को तो दिख रहा है यहाँ. जादू करो यार. प्ले करोगे तो चलेगा नहीं ना, ये तो प्रॉब्लम है. एक बार दबा दो, जाम करना, फिर ब्लॉक हो जाएगा. ये तो कौन सा व्यू दिखा रहा है? ये ऐसे ही चल रहा था क्या वहाँ पे पहले भी? एस्केप करो, एक बार नहीं 4 बार करना पड़ेगा. Parkinson for last 18 years. The magic is patient is off the drug. Magic is patient underwent DBS 8 years ago and she was not taking any drugs. Let me see if I could show the second video if it works. I'm not sure it will play. Again the problem of old videos. यार ये क्या हो गया? सारी स्लाइड दिखाओगे क्या ऐसे? ना. So at 19 years of his disease, I started levodopa again. So that's the magic. Sometimes if you have a best patient, you could have that kind of good result. That for next 19 years, 18 years, you are not taking any medication. डुप्लीकेट हो गया. किया क्या हमने? चल आगे जा रहा है, आगे भी नहीं जा रहा ना अब तो. अब तो नहीं जाएगा, छोड़ो. एक मिनट रुको, इसमें सेटिंग होता है ना जाके. उससे कुछ नहीं होता. उससे क्या होता? नहीं, अच्छा नेविगेशन में उससे कुछ नहीं होता है. वो बाप रे यार
डिस्प्ले में जाइए सर
डिस्प्ले डिस्प्ले इसी में होना चाहिए डिफ़ॉल्ट डिस्प्ले स्केल डिस्प्ले नहीं ये डिस्प्ले ऑफ है तो चल तो रहा था अभी ठीक तो चल रहा था स्केलर ये शो साइड में ये नहीं है छोड़ो यार
ऑप्शन
छोड़ो 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 कोई बात नहीं मैं लेट मी ट्राई ये कोई बात नहीं so doesn't matter we can continue so now somebody doesn't want an invasive procedure then what you do so now there is a new machine which you call FUS so it's a focal ultrasound what does it do you have a very high beam it's like radiation so you put 10 patient into MRI this MRI are ultrasound enabled and you put a very high focus beam and do a lesioning. Lesioning, previously we have been, lesioning has been done in last 50 years. As early as 70s people were doing lesioning. So what you do, you put an electrode into the brain and heat it up by 5 to 10 degrees centigrade so it will produce a coagulation. And that's how you produce a lesioning which is standard procedure. But somebody doesn't want to, कुछ तो होगा इसमें ऐसा नहीं है. Anyway, so people want to, doesn't want a surgery. So this is method where you could put a lesion, but problem is you can do only one side lesion. You can put bilateral lesion. Second thing, it is majorly effective in patients because you can do thalamic. You can't do STN. STN is a very small nucleus. So it's very difficult to do lesioning. Either you can do GPI or you could do STN. So it's not a very good method for it. Very recently it has been launched in India, which is in Kochi right now. But yesterday only somebody told me the one sitting cost is 22 lakh rupees. And when this company came to Medanta, the company talked to me and I said, they told me it is going to be costing 7 lakh rupees per session. And their calculation was so heavy, so I said, this is not financially viable right now. If I buy, then I will have to do at least 100 FES per month, which is practically impossible. And their major targeted patient with tremor. So I don't know how come they have started, that's why they come at 22. So those who are, they are deadly against surgery तो नहीं कराऊंगा तो वो ये जाके वो करा लेंगे 22 लाख रुपए में that's the story so I could cut this which is very well shown and very well effective method of treatment there is no doubt about it it's and it is FDA approved so MRI guided focus ultrasound thalamotomy is majorly done for patients with tremor whether it is a Parkinsonian, accidental tremor or all kind of tremor reduce hand tremor in patient with accidental tremor, which was maintained at 12 months period of time. That's another issue. The effect may not last longer period of time. After 3 years, 4 years, you may come back to square, and that then you will have to again think of what to do. Thank you very much for patient hearing.
Ultrasound guided thalamotomy.
Yes.
So I mean without surgery.
So it's a high focus beam.
High focus
It
beam.
centers at 1 and give it a very high dose. So it produces a lesioning.
Okay.
Yes. AIMS is planning to buy it now.
Oh, that's it. So let's move on with your next talk, sir.
Sure.
I think. Sure.
Yes, sir.
Dr. Vinay,
Sir.
recently we heard of they are injecting something Nanavati Hospital for Parkinson's.
Yes, it chalega nahi.
What is
Yes,
that medicine they are injecting?
Sorry, sir.
Nanavati Hospital, they have started, that two doctors have come from US and one from US and some other place, and they are now injecting.
That is apomorphine,
Uh-huh.
and he is Dr. Vinod Mehta.
Vinod Mehta, Dr. Vinod
He's
Mehta
from
and
King College.
Yeah.
So it's a story. Story goes like this. One company, Britannia, was planning to launch apomorphine in India.
Okay.
And they happened to do a workshop in Nanavati.
Okay.
Smartly, one gentleman, I don't want to name it here, collected those all videos of the workshop, made in 5 minute, 3 minute video, and put it on internet and told everybody that there is something like a cure of Parkinson. It was absolutely misleading.
It's misleading. Yeah.
Yes, as I mentioned, levodopa is only a rescue medicine,
Yes. You are right.
and last 2 weeks it is resurfaced again.
So I was surprised that how this can happen.
Sir, propaganda. So
let's-
company was worried that somebody will sue them in India. I say even if you spend some 2 crore rupees for the propaganda, you never had such a propaganda. So you got free publicity out of this small video. Which one,
Yes,
sir?
yes, they are doing, yes.
What is the cost there?
Which one? DBS?
Yeah.
I had done more than 350 cases. Currently at Medanta, it costs around 16 lakh.
You are at Medanta at present.
Right now I'm in Medanta.
So how much it costs?
16 lakh.
16 lakh rupees.
Yes.
Okay. Thank you.
Yes. Not this one. Okay. This is a little lengthy talk, and I might cut off a lot of slides because otherwise it will be very boring for all of you. So what I'm going to tell you is, we know Parkinson's disease is the one major condition where DBS works very well. So some of the slides may be repetition, which I'm going to skip. So these are large number of indications to do DBS. Some are neurological and others are non-neurological. To make it more fancy, you can do DBS for obesity and you can do DBS for anorexia. So that is the advancement now. It is not proven by FDA, but people have tried putting lead in somewhere or other nucleus. So for obesity as well as anorexia. So my joke is, after 10 years, if you don't have a lead in your brain for something or else, you will not be class. You will be outdated. But ऐसा कैसा आदमी जिसका एक भी ब्रेन में लीड नहीं है? Because there will be so many indications. Maybe hypertension के लिए भी lead आ जाएगा, diabetes के भी lead आ जाएगा, and someday we are all going to have some or other lead in the brain. So as I mentioned, we do brain MRI for anatomical localization. Physiological, I showed you MER. So these are some of the single cell recording. As you could see, STN is this kind of cell, and GPI is this kind of cell. When you grow gradually down, put your electrode down, you could see every cell activity changing. And by that you can localize you are in the right nucleus. These are some of the devices. This is the battery, which is like a pacemaker, which you implant under the left infraclinical lead. And these are some of the leads. Then this machine is a programmer. So we can program. It is just a simple electrical stimulation. So when you stimulate, either you will have voltage, what is the voltage, what frequency you want to give, and what is the pulse width. So 3 major basic criteria for any stimulation by electricity. I think we have already discussed this. So I just want to tell, so what are the advantages of using subthalamic nucleus? Best advantage is you can use bilaterally. In GPI you can't put bilateral, you have to do one at a time because that could cause problem. It improves freezing very well, it improves bradykinesia very well, it improves rigidity very well. The major symptoms of Parkinson improve very well with STN. It improves tremor also. I think for tremor after thalamus, this is the best nucleus which it can do. And as you know, levodopa dyskinesia will go down because your drug requirement will be less than half. So that is the secret. And as I mentioned, there is a great reduction in levodopa dose. What is the advantage of GPI? Patients who have severe dyskinesia, their rigidity is not that bad. That's an indication to GPI. Problem? Your drug will not reduce much. So still you will be taking same amount of drug. So if you have a drug-induced hypotension, drug-induced nausea, drug-induced cognition, or drug-induced sleepiness, so drug-induced symptom will not change. So that's the biggest problem. Though it will improve bradykinesia and rigidity very well. Tremor will also improve, but not as that of STN. Thalamus, what is the indication? Tremor is the only indication. Whether it is a Parkinsonian tremor or an essential tremor or any rubral tremor or any kind of tremor, it is the center for nucleus. Now what is the evidence? This was one of the earliest paper of 5-year follow. It was not a randomized trial. As you could see from here, the baseline UPDRS is a severity score of Parkinson was 55. And at 5 years it came down to 25. And that's what's clinically significant. As you could see from here, other study, when I look at this study, that gives me an idea. this is the best medical treatment. So if I draw, my pen is moving, okay. So if I draw a line after 10 years, it will go something like here, it will reach here. But if I draw a line here, then it will go down, 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 and then it will start increasing. So it will take 10 years. I think it will never reach the level it will reach in the best medical treatment. So that tells you that's a neuroprotective effect if it is there. This was a randomized trial which was published in 2012. I can pass on this very fast and look at the results. Oh no, this is a trial which I told you, which was very early, which was done in 2012 by Professor Charles. What are the good predictor of, how you predict that this patient is going to do well? If pre-operative dopaminergic response of motor is very good. When you give levodopa, so some of the centers around the world, in spite of confirmed diagnosis, they give 200 milligram of levodopa and look at the responsiveness. If the responsiveness is not good, he is not a good candidate for surgery. Age, younger the age, better it is. Shorter disease of duration. Recently we did a patient who came from Bangladesh. Patient who come from abroad, it is very difficult for them to come every 3 to 6 months. So we did DBS, and if you look at that patient, after 5 days, if I show you the video, you will never know this patient has Parkinson. She improved so well. The best part is she was taking 5 tablets per day. Today she is on 0 medication. And only 1 milliwatt, smallest of stimulation, she has done so well because she underwent surgery early. Absence of psychiatric effect. Those who are interested might know this, that there was a propagation in between that DBS may increase incidence of suicide. So there was a medical study which showed the patients with Parkinson have a higher incidence of suicide as compared to general population. But the patient who underwent DBS did not worsen this incidence further. So it is not true that it increases incidence of suicide. Out of my 300 patients, where there were 302 patients had attempted suicide. When we look back, both these patients had severe depression. And one of my patients was in psychiatric ward for 1 month before we could discharge him, and we were satisfied that he will go home and do well. So psychiatric disorder, especially having a psychosis or suicidal tendency, is a relative contraindication. So you first treat psychiatric disorder before you do DBS. Absence of postural instability, this is very important. The gait freezing, so axial symptoms, somebody has a speech dysarthria, he will not improve. Somebody has swallowing dysfunction, it will not improve. Somebody has a gait problem, especially freezing, it will not improve. Except the patient's freezing, one is levodopa responsive freezing, that will improve. But somebody who has a freezing in spite of taking levodopa, he will not improve. So we have to select that. I think we already talked about this. So as you could see, the levodopa dose reduction was 38% in STN versus only 3% in GPI. Dyskinesia was 89%, 62%, and clinically it was not significant. Cognition and behavior only in combination with STN, so other problem. Somebody who has dementia, the STN is not a good choice. The person who has the dementia is the relative contraindication to do DBS in STN, then I would do GPI. But usually I would avoid doing, because somebody who has a significant dementia, the likelihood of life, I would look into it. So somebody who does not have a 5 to 10 years or expected good life, I would not do DBS in this patient. Especially patient who are associated with malignancy. As those who are traumatically paralyzed and they may not be able to walk again. So that's not a good indication to do. We talked about NEPTA study. Thalamic DBS. As I mentioned, is predominantly. So look at who are the candidates: disabling medically resistant tremor, minimum bradycardia. So if there is significant bradycardia, that's not a good choice for doing this. So classically, what we call an ETPD syndrome. What is ETPD syndrome? I seen a lot of patients, they had tremor for 20 years. And they've been diagnosed as essential tremor. And now they are developing bradycardia. And when I do todite scan, their todite scan is abnormal. So is it essential tremor, or is it was Parkinson's disease, and that tremor came 20 years ago? So nobody has the answer to this. So what we call a ETPD syndrome, more likely. So there is also a postulation that all ET, given a choice, if they survive 200 years, will develop Parkinson's symptom. So there is a recent publication which has followed long follow-up ET patient. Those who underwent DBS for essential tremor, they have developed Parkinson's syndrome now. So I will tell you one more story. Last 2 years ago, there was a patient who was spinocerebellar electric etc. So he has significant tremor. For that reason, we did, I'll show you that at some point of time. We did DBS and tremor improved significantly. But the flip side was his ataxia worsened. So doing a DBS in a patient who was associated with other symptoms, the tremor will improve, but the other things, unfortunately, after 3 months of surgery, when he started doing well, he had COVID and he didn't make it. So I don't have a long-term follow-up for this patient. So look at what is the evidence when you do tremor. So this is a thalamic stimulation. This is a 6-year follow-up study. And at 1 year, as you could see, the baseline tremor score was 8.4. At 1 year, it was 2. And at 6 years, it was 0.6. So still, at 6 years, this is working. That's the point. What are the advantages? It causes significant reduction in tremor and long-term persistence. As I showed you, the 6-year data is available, which shows it works up to 6 years. I think we have seen this video. So we saw this video. Yes, dystonia. What is the indication of doing DBS in dystonia? They should be primary generalized dystonia. That's ideal case. So in that case, you should not have any metabolic disorder. His MRI brain should be normal. If you do genetic study and if it is DYT1 positive, I'll show you one case. DYT1 positive had one of the best results. Resistant to oral medication, generalized dystonia with preserved pallidum. Recently I had a patient whose pallidum is atrophied. Likely he had some insult at some point of time. And now he has developed generalized dystonia, the pallidum, there is barely any pallidum visible. So where do I put my lead? So we didn't select this case. On secondary dystonia. Secondary dystonia is following trauma, following cerebral palsy, because of drugs, because of hypoxia. If you develop dystonia following stroke, they don't do well. And around the world, people don't like to do it until there are compulsive reasons. We have done DBS in case of status dystonicus. So these are the patients who have come in a very bad state of generalized dystonia. They had impaired respiration. They are put on ventilator. Now what is the choice? So when emergency, we did DBS we did 4 cases at a time, and all 4 could be extubated, and dystonia gradually improved. So sometimes kind of a rescue surgery which you could do in these patients. So this was one of the earliest study of 22 patients with generalized dystonia. At 12 months, BFM score, which is a dystonia score, from 46 we went down to 21. As you could see, the patient who were DYT1, these 7 patients did remarkably well. I think I could cut short this. Just bad prognosis. So what are the bad prognosis patient? Patient with birth injury, falling encephalitis. So these are the patients, if you have dystonia, don't do DBS. This is a randomized control trial of 40 patients with this. At 3 months period of time, stimulation versus placebo, there was a significant improvement. From 0 to 6 months, it further did not change, so the effect remained up to the 6 months. But at 6 months to 3 years, there were further decrease in 34% of the UPDR score, which was significant. So this has shown that effect had lasted up to 5 years. So what is the longevity trial? So this study has shown that as you could see, the number of patients are gradually decreased. Up to 10 years, the effect is still persisting. So this is the longest data available right now. I am not sure this patient video is going to work, but it is a very old video. We did this in 2006. This boy at the age of 8 years started having dystonia. And by 11 years, so 3-4 years, so he has severe generalized dystonia. He could not sit. So whenever he says sit down, he was severe opposite posture. So he was always lying prone in the bed. That was his disability. He could not sit. He could not lie down prone. So when we did this surgery, this is 5-year follow-up. I remember this boy. 1 month after the surgery, when he came to follow up, he said, I'm not well. I said, what's wrong? Well, my neck is little tilted. Though he was never able to sit, now he is worried about this little tilt of the neck and he's still complaining that I'm not doing well. So this is 5-year-old. So this boy survived up to 8 years. And interesting part was, this was a very poor guy. And he didn't have money to get surgery. So we could beg and borrow and brought machine, which was at that time costing some 7 lakh rupees. We did it and he did very well. And suddenly his mama informed me one day that unfortunately he had a sudden cardiac arrest and he died. Sudden deaths are reported in patients with DBS. I don't know whether that was the case in this case. I have no clue about it. This is another patient. So look at this first video. You know, every patient will teach you something. He has a very severe generalized dystonia. His MRI brain was normal. It was a classic case to do in DBS. So we did DBS. Down 6 months, I don't see any effect. And it was very disheartening. So there are two ways of doing. Either you do something extraordinary which you have never done it, or say namaste. So I explained his father, I don't see much of an effect. So let me try something different. Well, it's whatever you decide. We used to stimulate only 4 to 5 millivolts. Here I went up to 8 millivolt, which I had never done it before. And when I went beyond 7, this is the stage. And when I went beyond 7 millivolt, you could see this video now. This is a little not as excellent video. There is another video I couldn't find. He is so working beautifully. Now 2 years he improved significantly. But unfortunately I don't have a long-term follow-up of this patient. When the patient become okay, they don't come back. When we did our first patient of DBS, he was from Kota, and for 1 year he didn't come back. And it was very disheartening. But something must have gone wrong, that's why he's not coming. And after 1 year he appeared suddenly. बोले अब मैं आ गया. बोले क्यों? बोले मेरा असर कम हो गया थोड़ा सा. So he came for programming again. So the moral of the story, सबको इतना ठीक ना करो कि लौट के ही ना आए. नहीं तो आपको follow भी नहीं मिलेगा इन patients का. So we talked about the secondary dyschronias. Classic example is PCAN. We don't call, which you know, NBIA type 1. So which is there is an iron deposition in bilateral basal ganglia. Betten syndrome, dystonia, deafness syndrome. These are examples where people have done this. X-linked recessive dystonia, Lubeg, which is a classic of Philippines, where you have hemi-Parkinsonian the Parkinsonian dystonia syndrome, which is very classic of Philippines. So there is a specific gene. Those patients are reported from around the world, but when you trace their ancestry, all came from Philippine ancestry. Perinatal hypoxia with bilateral GPI demands, people have even tried in this. Status dystonicus, as I mentioned, in thalamic hemorrhage. I think this is a Lubeg study. So let's, NBIA, there is a big study which is going on in Europe. They are collecting data from around the world. But I recently found out somebody who came from Germany, this data is not yet published. So we did one case, and I'll show you this. This patient has two interesting things. Can I put the sound card? I'll be lucky if the videos play. Oh no. Again same problem? No. It's working here. The laptop is on auto correction mode. Oh no. Leave it. So this was the patient who had Hallerton disease. He had a bilateral GPI. He has another condition which we call a adductor. I'll show you some of the videos in my next talk. Adductor laryngeal breathing dystonia. Normally, laryngeal dystonia is when you say spasmodic dysphonia. What is spasmodic dysphonia? When I am speaking, my vocal cord either get closed, what we call adductor spasmodic dysphonia. So I will speak like this when I am trying to strain. This is spasmodic dysphonia. When I am trying to speak like this, you must have seen somebody talking like this. And they are around you, but we don't diagnose them. And it is very easy to treat. Other is abductor type. What happens in abductor? When I am trying to speak, the voice gets hollow because vocal cords separate. So air will drop through the vocal cord and you will speak hollow. So these are when you speak. So what if this dystonia develops when you are breathing? So this is called adductor laryngeal breathing dystonia. So whenever I am speaking, I'll in between inhale, you don't hear my voice. But whenever they are talking to you, in between they have to because their vocal cord closed, so they have to strain to breathe in. So this guy had severe adductor laryngeal dystonia. To the extent when he came to the OPD, his SpO2 was 65. And I was frightened. So the father said, don't worry. ठीक हो जाएगा 1 मिनट में. ये हर 5 मिनट में होता है. So the father has seen it 100 times, so don't worry. And he assured me, but I said, no, take him to casual, but ठीक हो जाएगा. So sometimes their experience will teach you that everything is okay. So when we did, first time we injected him Botox. And probably the first time I had to arrange so many things in my ward, anesthetics and intubation and everything, because this guy who is choking like this, and I put a needle into the vocal cord, he may have a spasm and it will be terrible. But fortunately, nothing went wrong. When I injected for the first time, his speech improved so dramatically. For 7 months, he didn't come back. Again, these patients would never come to you when they are in trouble. So when I explained his father that let's do DBS. DBS is an uncommon indication to do NBIA. So this child is now almost 20 years now. This was a 5-6-year-old. So his disability is not marked. Otherwise, I thought he will never survive 20 years of age. So this is the way that you can reduce the long-term disability. And after doing surgery, he never had this. So probably it helped in that dystonia. Okay. So Meeks syndrome, what is Meeks syndrome? So it's a blepharospasm, is an eye, and then if your lower jaw involvement, which could be facial dyskinesia, jaw opening, jaw closing, neck, all this is called Meeks syndrome. This is one small example. So people even have done DBS in Meeks syndrome. Recently I had a patient from Iran, he wanted to get a surgery. But because his dystonia was so severe, either he will have to come every 3 months, which is not possible. So that's not a relative indication to more of a situation that he can't come, but he'll come back after 6 months for me. But they are very small data. So when you look at this is only 12 patient data. So these are anecdotal improvement. But if you look at this, at 12 to 78 months period of time, still 40 to 70% of the improvement was persisting. So DBS works in these patients. Segmented dystonia. Segmented dystonia is when they are dystonia in two adjacent part of this. So for example, head and neck. Neck and shoulder. Shoulder and trunk. So two adjacent part you have dystonia, that's called segmented dystonia. In that also we have done DBS and it works well. I think we already talked about this. I can skip this. Now, most of the time we do GPI as one of the target. But you can also do subthalamic nucleus. And these studies have shown the subthalamic nucleus is equally effective in these patients. So it's a very small study. I think we already talked about tremor. We could do DBS. So I'll show you one video. This is the patient which we did, the same gentleman who had SCA12. See, on OT, this is the tremor he had. It is a significant tremor. So he could never stop his hand moving. And on the table, as you could see, when he lifts it down, there is no tremor at all. The excellent response on the table. When you stimulate and you see the tremor is gone. When he's doing this, there is no tremor at all. So his tremor response was dramatic on the table. In Parkinson, on the table you can see he's going to improve so well. Tired-eye dystonia is another. So drug-induced dystonia, when they develop tired-eye dystonia, is another condition. As you could see, this is a tired-eye dystonia patient. And this is post-operative. There are a lot of other disorders like Tourette syndrome, OCD, and treatment-resistant depression. These are three another reason to do DBS. Tourette is especially those patients who have very severe Tourette's. Those who abuse the banging, they damage themselves, they damage around field around them. That will be indication to do DBS. Obsessive compulsive. I have seen patients who are so obsessive that they want family member to take bath every time they come out of the house and come back. जब भी घर से पाएंगे नहाओ, बाथरूम में चले गए तो नहाओ, तो बच्चे माँ बाप को बताए बगैर बाथरूम जाते हैं, क्योंकि अगर माँ ने देख लिया तो सारे घर को नहाना पड़ेगा, और फिर हर बार पूरा बाथरूम धोते हैं, पूरा घर पानी से भीगा रहता है, क्योंकि वो मदर वुड स्प्रिंकल वाटर एवरी टाइम. So these are the patients who should undergo surgery. I'm just putting the names. Huntington disease. So there was a patient of 6 patient study which has shown that it showed some improvement. We did one patient of Huntington disease some 5 years ago. And still the patient has, I cannot say the patient's chorea is less because there is no comparative parameter. But I would expect if down 5 years the amount of chorea what she had, she must have worsened more. But she is still independently mobile, which is good enough. But that's not a good choice because there are no further studies that come up. It means people are not liking to do. I think somebody must have talked about epilepsy yesterday. Aditya must have talked. Epilepsy 1, OCD is 1. We already seen this video. And no. Give me 5 seconds. I'm asking my neurosurgeon to give me a new video now. I can't play this because half of the time it doesn't work. What is left now? Okay. I think this was the last video. Thank you very much. If there are questions, then we can talk about it. Next, shall I take the third one now, or you want to have lunch and then we talk?
I think moreover, the fantastic, excellent coverage of both of these topics. Since, I was
People are
just
hungry.
discussing,
Yeah.
so, if you can just talk about, with or without PPT, how to approach movement disorder and the common medicines for each movement disorder, in brief, if that helps. So this is what we were looking at.
Okay.
We can, Botox, we may or may not, that's
Okay.
okay, because
Okay.
that's more of a
So
practical.
let's listen to the audience.
What, I think out of these, that would be
So
better.
I'll use my initially few slides, and they are more of a teaching slides.
Yeah.
So how do you approach to movement disorders? The approach to movement disorder, what is movement disorder? Any abnormal movement in the body is movement disorder, which could be jerky, which could be sinusoidal, which could be rhythmic, which could be non-rhythmic, which could be slow jerky, which could be large jerkies, all are called movement disorders, which could be habit forming even. जो बोलते हैं ना स्टीरियोटिपी, तो बहुत से लोग झटके मारते रहते हैं, तो वो भी स्टीरियोटिपी is a type of movement disorder. So to classify movement disorder, you divide them into two: hyperkinetic movement disorders, as its name says, and akinetic rigid syndromes. So these are two broad classifications. In akinetic, classical example is Parkinson's disease, and then Parkinsonian plus syndrome, and there are many of them. When you talk about hyperkinetic, then chorea, hemiballism, myoclonus, dystonia, tremor, tics, and akathisia. So if you see a patient with movement disorder, first you have to divide between the two. Is it hyperkinetic movement disorder? Is it an akinetic movement disorder? If you think it is hyperkinetic, then think about it. Let's talk about what are different things. What is chorea? Is it quick, irregular, semi-purposive, and predominantly distal? So it's like that. It's happening all the time, and he cannot control this. So this is chorea. What is hemiballism? Is abnormal, involuntary flinging. That's a characteristic. Fling. Those who get sometimes thalamic lesions, sometimes you will see this flinging. And hemiballism is one of the most disabling it gets, because nothing works in them. This lady which I showed you, 19 years, post-operative, she has severe hemiballism for 1 month. So if my patient develops hemiballism, I'm very happy, because they are the patient who are going to do. For that side, for 1 year, we did not stimulate at all. The stimulation was zero. So that tells me if you get little hemiballism, I say I'm very happy, because they will have very good effect. So abnormal involuntary flinging, large amplitude. It's not a small movement. It's a large amplitude movement of one half of the body, but it's never one half of the body. Most of the time it is upper limb or lower limb. Usually involves proximal, because that's how it flings your arm. Myoclonus. What are myoclonus? Myoclonus sudden, brief, jerk, and with a shock like, so it's sudden jerk. If you record electrophysiological, they are less than 50 milliseconds. On EEG you see myoclonus, sudden. The myoclonus can be divided. They could be focal, they could be multifocal, or it could be generalized. Classical multifocal example is PMEs, progressive myomechanical epilepsy. So how they do behave? They're constantly moving. So sometimes it gives an idea, is it chorea? Now chorea is not jerky. Sometimes there is a term called jerky chorea. But I think we don't fall into it. So classically, broadly speaking, chorea is a slow movement, rhythmic movement, and it's arrhythmic. Sorry, it's repetitive, but it's not in the same pattern. Every time you are moving differently. Whereas stereotypy is rhythmic. Stereotypy क्या होता है? Patients होते हैं ना झटका मारते थे. They can't stop. These are kind of mannerism. So stereotypy are very repetitive. They happen multiple times. Then how it is tic? Tic is going to come. Tic is, so these are abnormal involuntary movement which they want to do. It's an involuntary movement, mind it. Two important things to call it a tic. One, if they stop themselves from doing this movement, they will have constant desire. उसको बोलो सीधा खड़ा हो जाओ, हिलना नहीं, तो खड़ा रहेगा आधा सेकेंड, 1 मिनट, फिर वो इतना जोर से करेगा कि मतलब ऐसा लगेगा कि फट गया अंदर से. When you talk to them, they will say कि अगर तुम एक बार कर लेता हूँ ना, मुझे बड़ा अच्छा लगता है. So there is a constant desire to do that movement. It gives a gratification. they अच्छा लग रहा है. And if you stop it, it will exaggerate. That is tic. If they don't have this desire to do the movement, it is not tic. And it gives a relief also. One thing. Second thing, tic pattern will keep changing. I'm sure small children, you see them, they are blinking all the time, this. And after a few days, they will move neck. After 6 months, 1 year, they are moving shoulder. So these are simple tics. Simple tics, they're simple motor tics. So one particular time. Complex tics are they're vocal. They, they keep grunting, sneezing. Or more worse are when they start vocalizing. Vocalizing, then they sometimes become abusive and they cannot stop themselves. So I've seen videos, they abuse very loudly. And it's very embarrassing for them. So they know they are doing wrong, but they can't control it. उनको बोलें रुक जाओ अभी, फिर वो एकदम फट पड़ेगा, वो बहुत जोर से करेगा. Because that's the inherent property of the disease. That's how you define tic. Dystonia is abnormal sustained posturing. So my neck is this, abnormal sustained posturing, but it may not be sustained, it could be repetitive also. So there are two more things. There are two things which can be associated with dystonia. One is myoclonus. So with dystonia you can have certain jerks. So don't separate them. It's a part of dystonia. Second is tremor. You may have jerky movement because agonistic and antagonist muscle may not be acting equally. They may be acting at alternative. That gives the tremor component. So it is a pattern of dystonia. So abnormal sustained posturing resulting from simultaneous contraction of agonistic and antagonistic. If it is acting simultaneously, they will give a posturing. If it is containing alternative, then it will give tremor. With or without tremor or myoclonus. Tremor is rhythmic, that is the correct important. Rhythmic oscillatory, to and fro movement of a part. So it is along an axis. So I am moving it to and fro. I am moving to and fro. I am moving to and fro. So it's rhythmic and this is because of alternative. So there are alternative agonistic and antagonistic muscle contracting alternative. That's how it produces tremor. Next, I think video. Akathisia is something one of the worst thing. If you see this, it is a very difficult to treat disorder. What is inner restlessness with irresistible desire to move? What they do? आप उनको यहाँ बैठा दो तो वो बैठे पैर चलता रहेगा, थोड़ी देर बाद उठ के चल देगा, खड़ा होगा या. Okay, very good question. So when do you have RLS? Classically, RLS is when you go to the bed. When you're moving around, you don't have the symptom. In advance, you can have. So let me talk about RLS also. What is RLS? It's a constant, क्या वर्ड बोलते हैं हिंदी में उसके लिए, हड़कन होती है पैर में. दिस इज हाउ दे डिस्क्राइब. ये पैर में है ना हड़कन होती है, जब दिन भर काम करते हैं पता नहीं चलता है. When they go to the bed, that's where time they want to move their leg. When they move their leg, they feel better. Kulan is another word, yes. Or patient will start moving in the bed. रात में उठे, थोड़े चल के आगे सो गए, फिर सो गए. दूसरी बात, they will do very good if somebody will do massage. तो उनको मतलब 5 मिनट को मसाज कर देना तो बहुत अच्छा होगा. Then they can sleep well. Third thing, if the day was hectic, they will have more RLS that day. If they take a nap in the afternoon or evening, likely they will not have it. Fourth thing, RLS, if you have an RLS if you sleep, and if you get up from sleep, they will have more RLS. That will make it even more difficult to sleep. When you do that dopamine scan, they showed decrease in dopamine level. Why somebody would develop RLS and why somebody would develop Parkinson, I don't know that. What is the treatment? Dopa agonist. So Pramipexole or Ropinerol single tablet bedtime is good enough. You have to titrate it. But I have seen patients who may not respond to small dose. You can give gabapentin. There's another drug which works. The point is how long you give gabapentin. Dopa agonist you can give lifelong. I don't want to give gabapentin for a lifelong. So I write gabapentin or pregabalin as a SOS, rescue medicine. So what are non-pharmacological methods? कि आप तो थोड़ा सा रेस्ट कर लो before you go to the bed शाम को. Second, गर्म पानी से पैर धो लो. सोने से पहले गर्म पानी में पैर धो लो, उससे भी कम हो जाएगा. बगैर पैसे की दवा अगर कोई पैर दबा दे तो बहुत अच्छा है, पर सब जगह पॉसिबिलिटी नहीं है वो. तो यू कैन बाय अ मसाजर एट द होम. तो पैर रखिए मसाज में 10 मिनट सोने से पहले और सो जाइए. ठीक है. ऑल्सो देयर आर फिनोमिनास व्हाट यू कॉल ए एस्केलेशन. More amount to dopamine you will give, it will escalate. So today they are responding to 0.25 milligram, tomorrow they will respond to 0.5. Then they will get higher dose. So that's the problem. So avoid dopaminergic drug as long as possible. So give non-dopaminergic, you can give a rescue medicine. So try non-pharmacological methods. बोले पैर रगड़ने से ठीक होता है वो कर लो, गर्म पानी, ठंडा पानी, पैर दबाना सब कर लो. But keep drugs as a last rescue. I think we have discussed a lot about akinetics rigid syndrome. So, look at these videos. This is a patient who's barely able to move. When you get levodopa, look at the second video. She's moving so well. So this is classic levodopa responsiveness. And nobody can deny this is a Parkinson's disease patient. So what are symmetrical disorder and what are asymmetrical disorder? Classically, symmetrical is Parkinson's disease. Other is Leubank. Third is CBD. CBD is a corticobasal degeneration. Now PSP and CBD is actually clubbed. So pathology is almost same. One group of disorder may start from PSP, other group of disorder may start from CBD, corticobasal degeneration, and they merge. So sometimes you see a combination of that. So if time will permit, I'll show you some of the slides that what are the different types of PSP. Now there are 7 types, one of them being CBS type. They classically start with CBS, corticobasal. What is corticobasal degeneration? As the name said, corticobasal degeneration contralateral. So they hand develop sensory symptoms. So the what you call it primary sensations are retained, but perception, if they have their hand in the pocket, they can't find out where is the key. They can identify so stereotactic functions of sensory loss. They can identify it is a key, it is a coin. What is the size of the coin? What is the denomination of the coin? They can't find out. One of my patients, when I was seen agent, he came, he was a bus driver in DTC. बोले मैं जब इधर चलाता हूँ तो मुझे इधर वाला मैं स्टीयरिंग नहीं मोड़ सकता. Because hand will not follow the amount of force it required to drive. So you were developing CBS. I don't have the follow-up. Other is Leubank, as I mentioned, which is the asymmetrical dystonia Parkinson syndrome from Philippines. Classical symmetrical is MSA and PSP, but they are classical. If they little asymmetry, don't mind it. Especially PSP P type, which is the Parkinsonian type, it is classically asymmetric. And they respond very well to levodopa, but not as that of a Parkinson. So with experience, this is not Parkinson. It is PSP P type. And DLB. DLB is again another syndrome. In one group of patients, you may start with cognitive. Other group of you may start with Parkinsonian feature. And then it will merge. Parkinsonian feature will gradually worsen and they will develop dementia. Here, dementia will gradually worsen and they will develop Parkinson's disorder. So it's a spectrum of disorders. So when you should diagnose DLB? 2 things. Early onset dementia. Patient को 4 साल का Parkinson है लेकिन उसको dementia हो रहा है. That's not fair. Second thing, neuroleptic sensitivity. They have lot of hallucination. Third, the day-to-day variation. Family बोलती है कुछ दिन तो बड़े अच्छे रहते हैं, कुछ दिन बड़े खराब हो जाते हैं. कब कहते हैं सुबह बड़े अच्छे थे, शाम को खराब. This variation in their cognition and well-being tells you this is CBD. Treatment is like Parkinson if they have Parkinsonian symptom. It's like Alzheimer's if you have dementia-like symptoms. So you have to just decide what treatment is required. Skip this. I think I don't want to talk about Parkinson because just to show some of the videos, sometimes you are this drastic. These are called tremor predominant Parkinson. Tremor predominant Parkinson are around 15%. 85% are rigidity predominant. What is the advantage of tremor predominant Parkinson? The prognosis is better. I remember once I was in the market and I saw this guy has Parkinson. You always see this isko Parkinson है, isko dystonia, and you identify them. I said, भाई साहब आपको कुछ प्रॉब्लम है? बोला हाँ, Parkinson है. Dr. Bihari, my teacher, उनको दिखाता हूँ. कितने साल? 20 साल से. And then he showed me he's jumping. सब करता हूँ, दवा नहीं खा रहा हूँ अभी. So for 20 years he has only tremor, and he was jumping and doing so well. So in one way, tremor predominant is better because your prognosis remain long term better. So if you do DBS in them, they will do very good. Rigidity predominant, they will worsen and they will have more disability. Look at this patient. So these are some of the examples of. If you look at the brain section, this is substantia nigra, which is a dopamine. So it's a melanin pigment. Whereas in Parkinson, this is lost. So now there is a technique, you could do ultrasound and you can look at this pigmentation in the brain. And you can look at the studies, and if you have to be expert to know how much pigment is there. So non-invasive method you can try and see this is Parkinson. Now there are some 10, 15, 30 type of genetics. So the question should come here, if there is a patient of Parkinson whose father had Parkinson, son has Parkinson, should you do genetics? Anybody? Genetics is always a research tool. It doesn't help you in management. So my joke says, कि मैं आपको बता दूं आपकी 15 दिन बाद टांग टूटने वाली है. You want to know it? So don't do genetics. Don't jump on to do genetics in any patients. Until unless there are few indications, you have to consult. Somebody wants to be a pilot. I would do genetics to know, does he have a gene? The problem is, if he doesn't have a gene, he may develop Parkinson. If he have a gene, he may not develop Parkinson. और 40 साल के बाद आएगा, सर आपने कहा था मेरा जीन पॉजिटिव, मेरे को तो हुआ ही नहीं, मैं तो पायलट बनने वाला था. तो ये बड़ी प्रॉब्लम है जेनेटिक्स के साथ. एक एडवांटेज भी होता है, देयर आर लाइक पार्क 2. Park 2 is a classical type of Parkinson. They develop early Parkinson, they develop early dyskinesia, they do very well with DBS. So all these different type of Park have different type of spectrum of disorders. What are the red flags? I think this has been taught everywhere from MBS, BS to MD to DM and every teaching program. No response to levodopa is not Parkinson. Somebody is not responding to how you should try. Initially when it comes to your patient, you give 100 milligram. If there's been no 3 or 4 years of disease, you are doubting, give 200 milligram of levodopa and look at the response. How do you look at the response? I always ask them to make a video and walk fast. Make a video, give 200 milligram of levodopa, after 1 hour walk fast to the same place. And look at, compare your videos. And even the patient and attendant, you will know there is no response, there is no effect. You know this is not Parkinson, this is atypical Parkinson. Cerebral signs. So these are absolute no. At no stage you have cerebral sign in Parkinson. If it is cerebral sign, it is not Parkinson. Cortical sensation, which I mentioned CBD. So look for cortical sensation. If they are abnormal, it is not Parkinson. Alien hand phenomena is that उनको क्या मेरे को पता ही नहीं चलता मेरा हाथ कहाँ चला था. एक पेशेंट था वो ऐसे ही चलता था. तो he knows उसको हाथ यहाँ रखना नहीं जाता है, हाथ ऐसे हो जाता है. There is abnormal posturing. This is called alien phenomena. Impaired vertical gaze, or what we call as supraorbital gaze palsy. When you examine vertically gaze, don't look at there is a palsy, look at the speed. The earliest sign is vertical seconds get slow. When you look up, look down. When I look up, down, you can do very fast. If you see a patient and if they, यार तुम audience के आगे आगे खड़े जाते हो फोटो के चक्कर में, इधर आ जाओ. ये बहुत देर से नोट कर रहा हूँ. एक दिन मेरे आगे भी खड़ा हुआ था. फोटो इतना important नहीं है बेटा. So when you are looking at the vertical, when try yourself. You can look up and down very fast, in fraction of seconds. If you have any doubt, check his attendant's eye movement. You will see this is fast, this is not fast. Similarly, in initial rigidity, if you find rigidity lag to raha hai, check his attendant. Then you realize that immediate comparison, you see no, ye to bilkul soft, ye nahi hai. So this early stage, you can always compare it, and you know this is not normal. And pyramidal signs. Pyramidal sign is a softer sign. Because everybody may have a disc in the neck and that may give a pyramidal sign, so that may not be a very strong sign. So early red flags. If you Parkinson patient will fall ultimately, but if you early falls, so falls within first year is a no-no for Parkinson disease. Cognitive changes, as I mentioned about, autonomic dysfunction. In male, you should always ask history of importance. People hesitate to ask, but this is a very important early sign this patient is MSA. Single question. If ask is, it is positive, it's not PD, it's likely MSA. Lack of response to treatment, I think we did that. Symmetrical onset. Parkinson is classically asymmetrical. If it is symmetrical, you should doubt, ये Parkinson नहीं लग रहा है. Ultimately, at 5 years, you will know this is not responding very well. Dysarthria and dysphagia. आवाज़ साफ नहीं है. Think, is it early stage में हो रहा है? This is not Parkinson. Let's look at some of the videos. This is classic Parkinson, asymmetrical tremor, rest tremor. Same guy when you're given a drug, he is having dyskinesia. So is dyskinesia a good sign for Parkinson? Practically yes. But this is not 100%. Sometimes patients with PSP and MSA may develop dyskinesia. The point is disabling dyskinesia, they never have it. So if I have to try to give 200 milligram of levodopa, you'll have massive dyskinesia. That will not happen in atypical Parkinson. But don't give 200 milligram. You will be devastated. But sometimes I think I don't want to talk about it. So let's look at this patient. Is it a video? How you look at this? Look at this stare. This stare tells you this is not Parkinson. This is PSP. The key. Other thing is they can't move their eyes, so they move their head all the time. When they are talking to you, they move their head because they cannot move their eyes. And this stare look will tell me this is PSP. I don't have to examine his vertical eye movements. It's very clear. So radiologically, what you call a hummingbird sign. So have you seen hummingbird? Go and check your net. So this is a, normally I should have kept it parallel. So you could see this is beak. This is a beak phenomenon. This is called beaking. So there is a thinning of upper part of midbrain. That's called beaking. And if you compare it with the belly, this has become narrow. And it looks like hummingbird. That's why it's called hummingbird. There are many signs. Yeah. This, so look at here. Again, this is narrow. And then this is something like, Mickey Mouse sign. They've given a lot of names. So this peduncle here is atrophied. And that leads to the ear shape of the Mickey Mouse and what you call it a Mickey Mouse sign. So PSP in Parkinson, rigidity is predominantly in limb and less in axial in Parkinson. Whereas in PSP, so how do you check for axial rigidity? Stand behind and move his shoulder. When you try in 5-10 patients with Parkinson versus PSP, you know how much is the rigidity in the early falls, PSP. Tremor, usually you may not have tremor in PSP, but in Parkinson you will always have a tremor. Down gaze, eyelid apraxia. What is eyelid apraxia? What is apraxia? Any DM student here? सब गायब हो गए. हाँ. It may not be skilled, na? Learned motor activity. Correct. Correct. So apraxia of eyelid is when I close, I can't open my eyes. That's eyelid apraxia. Which I don't agree with this. It is more common in PSP. It can happen in Parkinson also. What is the treatment? याद रखना जब भी सवाल पूछूं बोटुलिज्म टॉक्सिन बोल देना. You will be correct. So getting symmetrical, emotional incontinence more in PSP. Levodopa response is weak. So these are the types. Predominantly Richardson type. You may have a predominantly Parkinson P, which is the Parkinsonian type. PIGD, those who are predominantly gait involvement. PSPC is extremely rare. So don't diagnose a PSPC. There is a classical patient with Parkinson, a subtle cerebral sign, which is called PSPC. PSPSL, that is spastic type, as I mentioned, they have significant spasticity. PSP-CBS, which is a very common thing. If you examine carefully, they will be asymmetrical and they will have corticobasal signs. And PSP-F is FTD, frontal type. Now there is another syndrome called FTD 43. There is a protein called FTD43. Sorry, TDP43. So TDP43 protein gets accumulated, that also causes syndrome. And this is a mix of it. It can cause dementia, it can cause Parkinson, it can cause PSP-like symptom, it can cause ALS. So huge amount of disorder it can cause. We talked about it. Multiple system atrophy is when you have not only Parkinsonian feature but associated two more things, cerebellar and autonomic. Those patients who are predominantly cerebellar, the autonomic will be there in all. They are called Parkinson's, MSS type C. Those who are less cerebellar but predominantly Parkinson, they are called MSS P. I think I stop it here because this MRI one can see this is a classical hot cross burn sign. If you see an MRI of patient with Parkinson feature, and if you see this in Pons, this is called hot cross burn sign. You can see what is hot cross burn. Then this is classical for MSA, but is not exclusively for MSA. It will be described in 10 more disorders. Then drug induced, and these are a lot of drugs which are. Shall we stop it here? Take a lunch and then come back?
We have a workshop.
Okay, then I think stop here.
So maybe if I think we can maybe stop it here.
Yeah.
So
This is already 3 o'clock.
yeah, thank you very much. I mean, it's been. I mean, thank you so much. You spoke so long and you must be exhausted. So big round of applause for Dr. Vinay Goyal sir.
Thank you, sir.
You
नहीं मैं एक क्वेश्चन पूछना भूल गया बिगनिंग में कि मेरे को कितनी देर बोलना है.
you can actually. So anyway, so it's been like we have exceeded time, but since it was a course relaxed environment, but we have neuro rehab and one nursing workshop after the course because they are the, they are also a stakeholder and they have to be
Correct.
trained and is given this kind of training. So I thank you very much. I mean, all of the faculty speaker took all the pain to come here and teach us. All the senior physicians, neurologists, my colleagues, my students, everyone, and especially all the senior people like Bam Saab and all the senior physicians who have come from outside. You took your time out. Hopefully it was of use. It was a brainstorming session from last 1.5 days. And obviously my whole organizing team that includes everyone. So it would be, very difficult to name because everybody was working for this meeting. Those are not here, some of those. So I would conclude, and last thing I want to say since this course is a regular activity, so please do give your feedback and inputs so that next time we may improvise on this, and depending upon the needs, we can actually, structure the whole program. So whatever
I'll
suggestions.
interrupt here. We must congratulate Atula for doing it consecutively 9 years. Large number of programs in country which start, they stop after 5 years because they can't sustain. So when I came, I told him still your hall is full. So I was so happy to see. For a speaker, you only want one thing: audience. If there is no audience, you don't like it.
all the senior faculty members who comes and teaches. We learn in the process the most. So thank you very much once again. Disperse for lunch now. Thank you.